Good afternoon, everybody. Welcome to this meeting of the Health Overview and Scrutiny Committee at County Hall. This meeting is being broadcast live via YouTube and will be available for viewing on there after the meeting. I'd ask you all to turn your microphones on and off, on when speaking and off when you finish speaking. We're not expecting a fire alarm, but if the alarm should go off, please exit the committee doors via whichever door you came in, turn right, go through the double doors, down the flight of stairs, which leads to 2 fire exits in the outside world. Well, we haven't done it yet, have we? Although I have been here when there's been fire drills. Anyway, that's another story. With regards to committee membership, since the last meeting, we've lost Kevin Crook, as he's now deputy leader of the council. Replacement from the Reform Group has not yet been nominated. Welcome to everybody else. I was going to say welcome to Mr. Squires, but he's not here, so I can't. So first of all, first item is the minutes of the meeting on the 4th of June. Now, since the last meeting, there's been discussions between the lady who submitted the questions, Rachel Moore, and the ICB regarding the question they answered about GP practices. Mrs. Moore queried the part of the answer which said 100% of practices now offer online bookings for appointments either on the same day or in the future. Since the meeting, the ICB have provided further clarification that says all practices in LLR have the ability to offer online bookings already. Now, whilst the minutes correctly record what happened on the 4th of June to those who are in the room, I'm going to suggest we add a minute giving the later clarification provided the ICB as a proper record of actually what's gone on and the facts. So is everybody okay with that? Thank you. I don't think there are any other amendments required to the minutes, so we'll move on. Note them as being accurate. Questions. We have had 2 questions from a member of the public, Rachel Moore. She's been provided with written answers, and the answers have been published on the website. Rachel, do you wish to ask a supplementary question on either? The supplementary must be to clarify the original answer and not to raise new issues. Thank you. No, please come around so we can ensconce you into our technology. Yeah, thank you.
I wanted to know, obviously since my daughter's suicide last November, I've been doing a lot of reading and looking into sort of care in Leicestershire. And in the minutes of the LPT's safety briefing, in their LPT minutes, it says that there have been gaps in suicide prevention training. They've given me an answer here saying that they've purchased this new Storm suicide prevention training, but I want to know what were those gaps in suicide prevention training, who wasn't getting trained, given that the person that was seeing my daughter used an outdated risk stratification method and assessed as low risk when there is no such thing in suicide, because impulses, suicidality can change within minutes or a minute. So I want to know what were the gaps in training, and obviously they've provided us with an answer about what's happening now, but what were those gaps, who wasn't being trained?
Okay, thank you for that. Can you just turn the mic off for me, please? Thank you. We'll get LPT to give you a written answer to tell you, and it'll be by roles rather than individuals, obviously. But yeah, we'll get them to write to you and give you a follow up to that, if you don't mind.
Okay, thank you. Sorry, just about the GP thing. They have admitted in an email to me that 100% of surgeries don't offer the same day or the next day online booking with a GP. I can forward the answer to you.
Yeah, that's what we said. They've retracted and said they have the ability to do it, which isn't what we were told. So that's why we're going to amend the.
And also some people, pensioners, aren't able to get medications from surgeries. They're being asked to use NHS app or online, and they're unable to get the medications because they don't have access to the NHS app. They don't have the internet, and they're not given any other provision to get medication. Because that's happened to my mother-in-law. You have to at certain surgeries, which I've forwarded to the LPT. So hopefully they're looking into that now as well for us.
Okay, thank you. Sorry, we haven't got any questions raised by members. No other urgent items. Do we have any declarations with respect to the agenda? Mr. Poland.
Thank you very much. In respect to agenda item 11, mental health and early intervention. I'm a trustee of the Loughborough Wellbeing Centre, which is a leading mental health charity in Leicestershire. So I think that's relevant, and I thought I'd declare that.
Thank you, Mr. Mear.
Yeah, my sister works at LRI, so.
Thank you. Mr. Piper.
Yeah, I'm, as I said last meeting, I'm a member of the Mary Guppy group, which is trying to preserve the hospital in Lutterworth, which may come up under one or two different sections in today's reports.
Okay, thank you, everybody.
Sorry, Chair, if my mother works for the Leicester Health Partnership as well. So.
Okay, fine. Be done. Better safe than sorry, to be fair. I'm assuming there are no declarations of the party whip. No, good. And there are no petitions presented under Standing Order 36, so we're swiftly on. That's about as swift as the agenda is going to go today, I fear. To item 8, the NHS 10-year health plan. So we've got Pete Burnett, Chief Strategy Officer of the Integrated Care Board, to come and have a chat with us. To you.
So, thank you for inviting me in. For those of you, probably most of you don't know me, I'm Pete Burnett, Chief Strategy Officer for LLR ICB, and I've been in post since June. So those who have been here previously might have known Sarah Prima, so I've taken over from her role in that sense. So there's two items on the agenda. They are related, but I'll go through the 10-year plan piece first, if that's okay, and then I'll take on the clustering ones. If that's how you want to do it, I can do them both together. So, but I'll go through that one first and then see what question comes from. So, government published its 10-year plan on the 3rd of July this year. It's in response to the Darcy report that looked into the state and health of the NHS, that basically said, obviously, it is in need improving. We need to improve how we deliver care and where we deliver care and that kind of stuff. So the 10-year plan sets out the government strategy in how we're going to address the issues identified in that. So clearly patient satisfaction is at all-time low. The ability to get planned and unplanned care is taking longer than we'd hope it to take, and there's financial sustainability issues that we kind of need to address. So in terms of how the government or the policy states out how we're going to do this, it puts three kind of key shifts it wants to see take place. It wants to see hospitals to community, so taking services, not necessarily taking services, but taking the activity out of the hospital setting into the community, into people's neighbourhoods, into their homes to actually get the treatment actually where they live, rather than having to go to hospitals in the long run. Clearly there is a need for hospitals, it's not to say there isn't, but that is the key kind of emphasis of that shift. Alongside that, they want to digitalise the NHS further, notwithstanding the issues not everyone of any of all age can access kind of digital solutions, but drive the use of digital, both through the patient's experience and ability to kind of manage their own care, but also through actually some of the digital kind of technologies that can enable healthcare to be delivered within hospital and neighbourhood settings to actually give the kind of clinicians more time back to do the work that we want them to do. And then the final shift is around shifting from sickness to prevention. So trying how do we kind of stop people getting ill in the first place to reduce the need for health services we go through. So I just touch on some of them because I know the paper have been read, but just to cover the key points really. So the hospitals community is kind of the key foundation of the policy as it takes as it moves forward. There's a commitment to have neighbourhood health hubs, and in the first kind of period of Parliament to have around 40 to 50, but over the course of the kind of 10-year plan, have to about 250 to 300 across the country. And the neighbourhood health hub clearly being a central area that actually patients can engage with, come and see services, but also before we get to it, it's not about the buildings, but actually how do we get teams into communities to support the right patients so they actually get the care locally in a planned way so they don't access unplanned care in the way the numbers we have at the moment, because we know our population is growing older, we know people living with comorbidities, so how do we put care in place to kind of support them live their lives as healthy and fulfilling as they possibly can without having to have long hospital stays or go into, and that's both physical and mental health kind of stays, how we can support them live their lives in the community. So that's the key piece of the policy, what it's trying to shift. The analog to digital, as I said, there's a key focus on using the NHS app, giving patients the chance to book their own appointments. So if you get an outpatient appointment at the moment, you'll get a letter telling you when your appointment is. Actually, that's quite outdated in terms of all the stuff you do in your life. So how do you shift that so you have a choice of when your appointment's going to be? You book yourself into that. You can feedback using the app about the care you're getting, or if you're within neighbourhood team, actually any issues you might be having that day, or kind of how your care is in that respect, in that sense. There's also Health Store in terms of apps and kind of podcasts and stuff like that to help people support their own care outside of health settings, to help them go through, and a single patient record, so actually all our clinicians can see the same key information on patients as we go through. And the other element is around AI and how we use like scribes to take notes. So actually you haven't got people writing up letters, it's done quicker, so people get the information in a more timely manner, and free up our clinicians' time to treat the patients we need to in that sense. And the other final bit, really, without going to, and I'll just touch on the wider bits of papers, is the sickness to prevention. So the policy that's going through, or the legislation to stop to have a smokeless generation. So people who were born before 2000 or after 2009 won't be able to smoke. The kind of mandatory kind of requirements around health labelling around alcohol, obesity targets and food legislation, that kind of piece. So a shift to try and prevent people getting into ill health in the first place. The main part of the 10-year plan focuses on the operational model, which I touch on in the next agenda item, around restructuring how the NHS works, having a national quality board to oversee quality and care delivery across the NHS, a new workforce plan, because currently the previous workforce plan sees quite a big growth, and actually the aim is that's unaffordable. So how do we train our staff to the right level and have the right numbers of staff locally, and then also try and their key role is to bring the NHS back onto a stable financial footing, so actually it lives within its means, rather than having posting deficits at times across England, essentially. So they're the key elements within the 10-year plan. I'm happy to take any questions.
Okay, thank you for that, and thank you for not ploughing through all the slides. Have any questions? Cool.
Yes, thank you very much, and thank you very much for going through the. Yes, we did go through the slides. I just had a couple of questions. One about the tech. I think yes, that if the NHS app is the way it's going, that should be the go-to point for people to be able to access immediate care. I think like GP care and all the rest of it, not emergency. Obviously, you need to go to LRI for that, or whichever hospital. However, the amount of money that we spend on the NHS and the amount of money that we actually spend on the technology seems to be out of kilter, because we spend, I think it says it in one of the reports, 38% of government spending is on the NHS, yet the technology on the NHS app, I've had it on my phone for 2 or 3 years now, hasn't advanced anyway that way. So is there a disconnect between what we're saying and actually what we're delivering? So that's one of the questions I've got. And the second one is more to do with the practicalities of the NHS and upskilling the staff that we've got, because there's about 5% of people that are always constantly sick in the NHS. I don't know how that compares across the area and the districts, but if we want to get people coming back into work and feeling valued, I think the things that you're doing with like the nurse consultants and all the rest of it is really, really good. But also the other thing, and the final point I want to touch on, is the recruitment from overseas. Because this year in the press, we had people not being able to get jobs in the NHS, nurses not being able to get after graduating get jobs. So how does that marry that we're going out to abroad to recruit, but then not having jobs for people who've graduated here? Thank you.
Thank you. So I'll take them one by one in terms of some of the answers actually will require, I can give you the narrative, but the workforce bit will be governed by NHS England as we move forward. But in terms of the app, I agree. I think the level of funding that goes into that, if you compare that app, in my view, compared to lots of other apps you will use, it is clunky, to say the least, in that sense. So it needs to be improved. What has happened in recent years is that the capital funding that's earmarked within the NHS, and some of that aligned to digital, as the NHS overspends, actually gets that budget reduces, and it kind of props up the deficit position of the NHS. So there's a kind of wondering, how do you get through that, and actually becoming more digitally enabled will help us deliver better care and a reduced cost, and that app is crucial. So I think the commitment in the plan is that won't happen, but the government budget, the NHS and the national team hold the core budget in terms of that kind of app development and some of the kind of solutions in that space. So I think that's the intent from the plan, but we'll have to see how it goes through. I think that does require the NHS in all our settings to get back onto a balanced footprint to kind of stop that happening, and that's kind of also what the plan's trying to do. But I do agree there needs to be more investment into it, and it's a tricky solution because it's not like every organisation uses the same tech. So if you've got a booking solution, the app's trying to book into everyone's every hospital bookings option, but not all hospitals have the same ones, so suddenly it becomes quite complicated. Where if it was HSBC's app, clearly all their technology is the same. So there's a lot to it, but I do agree there's need more money into that. In terms of the workforce side, so clearly upskilling people, making sure they be valued in their job, making sure that actually they're getting the training they need is crucial. There's going to be a development of a new workforce plan alongside this, and so that will obviously articulate how that will happen. But those new roles like nurse consultants and stuff will form part of that. I think with the overseas recruitment, there was a commitment this year in terms of reducing overseas recruitments for the exact reason you said. We have people qualified that then can't get jobs. So there's a commitment to kind of reduce our reliance on overseas staff and how you retrain our own. And I imagine I'll see that in the workforce plan.
Thank you. I must admit, I have seen a diagram of Barclays' internal computers systems, and if you think they're straightforward, I think they might they've got some hellish legacy stuff. It's unbelievable. Anyway, that's aside. James, you're next on the list.
Thank you. Questions actually follows on really, but in regards to use of technology and specifically AI in sort of the future of healthcare. So obviously a big problem that we all know about is the access to GPs, the 8 o'clock rush, being able to get an appointment at all and all of those sorts of things. And I'm aware that GPs are increasingly using AI to help them with their appointments, and that's absolutely to be welcomed. In terms of looking forward 10 years or even beyond, though, I just wonder to what extent actually we could really embrace AI almost on a patient direct level. So we're already at a point whereby doctors routinely use AI because clearly not everyone can store the entire knowledge of the internet in their head, and it's a great way to sort of diagnose issues and do it quickly and so forth. Could we get to a point where we can develop an app, though, effectively whereby patients could directly talk to an AI doctor, for want of a better description, for routine things that potentially would unlock a whole load of different potentials in saving GP appointments? Because obviously if you've got an AI doctor, you've got an infinite amount of appointments, haven't you? And I really think we're maybe not there with the technology now, but I know we're not billions of miles away from a place where we could be there if we've got the will to do it, if we've got the time and money to invest in that. And as I said, if we could get somewhere even close to that, that's potentially a game changer, I think, for entry to the NHS. Just wanted your view on that.
So I'm not a clinician, so there's a danger of being in terms of saying what we can do, and I'll let my clinical colleagues know, because obviously clinical governance around who owns that patient and the information they're given in terms of making that true. But there is a commitment. It needs to be the most AI-enabled healthcare system in the world. How you measure that, I don't know, but there is definitely a commitment to freeing up, say, general practice time, so you can get digital appointments, you can seek digital solutions, some of the kind of minor kind of illnesses that actually don't need to see a face-to-face time with a general practice clinician, so they can spend their time with the patients who really do need that element to it. But I think there is a real commitment to try and do that, and also self-care through different health apps and that element. But there's also the ability to use for patient data, that they have wearable technology that monitors their own health, that actually then flags to their kind of local clinical teams. If you think it's part of the neighbourhood health, it flags that actually they have a heart rhythm that isn't quite right. They don't even know it themselves, but actually it's getting picked up and being identified to their clinician, so it's proactive in that space. So I think there's a lot to do in this. It's all the scribing and scanning of kind of images to see if there's kind of cancerous or if there's breaks and that kind of stuff. There's elements of that that can go through, but I think there's a lot that can be done in this space if we embrace it.
Okay, thank you. Now we're going to go to Hardeep Chauhan, who's online, it's unusual to let anybody come in line. There's two reasons for that. One, she's from Health Watch and they don't vote, they just comment. And two, the person who's supposed to be here is unfortunately in hospital having broken their leg very recently. So she's a bit of a late emergency arrival. So Ewan, if you'd like to wrangle the technology for us.
Yeah, should do that.
Okay, just reveal yourself, as it were.
Hello, thank you so much for that lovely introduction. Yes, so I am covering cash today, and just for a bit of background, I'm Hardeep Chauhan and we manage the contract here for Health Watch Leicestershire at Val, which is why I was asked to cover, and I have been to the Health Overview and Scrutiny in the past, so I'm quite familiar with the format. It's not a question really, it was just to say Pete was actually with us yesterday, engaging with the voluntary community and social enterprise sector around involvement with the sector and the local community around the 10-year NHS plan. So it was just to offer you a bit of insight into that. And as Health Watch, we hear a lot about digital use and the NHS app from the patient experience and the intelligence we have, and we will be feeding that back and continue to feed that back through ICB in terms of sort of the developments with the digital side of things, because that is one of the areas we do get a lot of feedback on. So it's just to make you aware, Chair, and everybody else with a little update. So not a question, but more of an update. Thank you so much.
Thank you. Mr. King.
Yeah, thank you, Chair. Thanks, Pete, for your presentation of the government's 10-year health strategy. Unfortunately, I'm struggling to understand how this relates to LLR because you haven't spelled out any of the local 10-year strategy. So that's just first point. The second point I want to make is in this health strategy, a lot is made about a single patient record. Now, those with slightly longer memories will know that some years ago there was an attempt to do that. And that cost the government, the taxpayer, £16 billion that had to be written off as the health system tried to do the single patient record. Infamous that was. Absolute scandal. So I hope we're not going to go down that route and the government's not going to go down and create that mess again. Just in this presentation, there's nothing mentioned about waiting lists. And what's going on at the moment, in my experience, is waiting list shunting's going on. So you get offered an appointment and then you promptly get put on a waiting list for 2 years before you actually get seen by a clinician. And again, what this is, I mean, it skirts around the issue. It doesn't actually talk about it, but this is all about increasing productivity. It's about increasing throughput. But we don't actually say that explicitly. The government doesn't talk about that. I mean, maybe it doesn't like to talk about productivity. It has handed the health system an awful lot of money in the last 2 years, last 18 months, sorry. Salary increase, massive salary increases, and yet strike action and all that's still going on. So just wanted to understand that. Next thing is, in the slides, it says government expenditure is 38% on the NHS of all government expenditure. So my quick calculation of that, government expenditure according to the OBR is £1.3 trillion in 24-25. So that makes that £456 billion a year. But according to the OBR, health and social care is only £190 billion a year. So what does the 38% of government expenditure figure relate to? Is that 38% after certain other things have been taken account of, or is that the £190 billion a year that the OBR says it is? I'm just trying to understand because there seems to be an incompatibility. I appreciate you may not have written these slides, so you may not be able to answer that, but it is factually incorrect. So that's just trying to understand that. The other thing I wanted to just understand, a lot of the users of healthcare are basically older people. Okay, some of us in this room all fit that category, including myself, unfortunately, and young people, very young people. Now we're talking about, and my colleagues and youth and the NHS is talking about digital apps. Okay, that's great. One of the problems as you get older, one, your eyesight isn't as good, your manual dexterity isn't as good, and also, you know, people get older, they get, you know, ill health and they get conditions, and their memory and their cognitive ability isn't as good. So then, how does this use of AI? How is that going to be able to deal with the fact that someone may not be able to operate, and given they're the heaviest users of health services, how are we going to deal with that? And that just brings me very neatly to a situation that we have locally, where the local medical practice that I'm a member of recently activated a system called Rapid Health as a means of, you know, because a pilot, but that doesn't integrate with the NHS app. So you can't actually use the NHS app, but we're all encouraged to have to actually book appointments anymore, because you've got to use a different system that's being trialled. So again, I'm just trying to understand if we're going to be keeping what we've got, as Mr. Meir said, and trying to enhance that, or we're going to ditch what we've got and have a brand new system. This again, I appreciate there's a lot of detail here that you may not be able to answer. Staff training. Now, you know, great. All of our staff, they need to be properly trained, need to be professionally trained, because, you know, who wants to be treated by someone who isn't? But what I don't understand is the government's obsession with, and a health service obsession with, recruiting staff from abroad, when we've got plenty of people in this country who aren't working and who would probably be quite happy to, and be, you know, as I understand, there are more applications than places on most courses in the UK. So what I'm not understanding is why it's necessary for the department, you know, for the NHS system to go and recruit people from abroad. And that's been going on for years. Why can't we just recruit enough at home to begin with? And then if we do need specialist top-ups in particular shortage areas, then we go to recruit. But to have, you know, the vast numbers that we have at the moment. So is that something that we're going to see a change by this 10-year plan? And that's it for the time being. I'm sure there's plenty of other points, but I haven't had time to come up with those. And I've only got a limited amount of time before Dr. Hill's going to tell me to stop speaking. So thanks very much. Thank you.
But to be clear, I'm not here to represent the government. This is their policy, and some of those questions relate to you need to be directed in their direction. I'm here to tell you what the policy says, which is, and as someone who works in the NHS, it's our role then to roll out that policy, feed into it, support its development, that kind of stuff. So I can't. Some of those questions is directed at the wrong person.
I understand.
I'll try and touch on some of them. So what does it mean for LLR? We've already got neighbourhood health. We're already working on neighbourhood health plans, both in the city and the county and in Rutland. And we have joint teams who are working that across the local authority, working with public health, working with the local voluntary sector in these areas. But obviously the policy itself was only released in July, but that work's been going on way before that been going on way before it got released. So that work's already underway. Also got a lot of work taking place around prevention, again, working with Mike and the team within the county council in terms of that. And so so it's not new to some extent. So it's about how you take that plan forward. The next step actually is for NHS organisations develop a five-year plan. If you look at the way the NHS is run, it's always 1 year cycles of planning, and doesn't matter who's been in power, that's been the case largely. We've now got to develop a multi-year plan that says how we're going to kind of develop the plan and deliver the plan as it goes forward in that respect. So this work is underway already in the county. So it's not to say it's new, but there's obviously how do we take that forward then in the ask of this in that sense. In terms of a patient record, so yeah, the NHS has understood it back then, did try and have one system. We now have something called a shared care record that actually interfaces with all the different records that we have, that allows people to see a kind of a summary care record of the patient in front of them, putting on other people's systems rather than having one big system for everyone. The point is, how do you enhance that and actually make sure that so the clinicians in front who see the patient is sat in front of them can have the kind of the history and the story around that patient, so they don't have to ask them multiple questions, and to some extent using the app helps in that respect. So not saying it's not one way it's doing that, but Leicestershire does have a shared care record, so you can access that. You can see what other people have put in the care record and see what kind of other interactions they had taken place in that sense. right at the back of to be fair, the aim, I'm sure, from the government in terms of policy is delivering productivity and bringing the NHS back onto a stable financial footprint. Talks about a 2% productivity gain at the end in terms of taking that through. That is a key aim of what they want to see happening in that. And then when the 10-year plan, when our multi-year guidance comes out about the 5-year plan, it'd be interesting to see what what's required as part of that. Last year we had productivity packs, for example, across organisations, and where as an organisation we could improve. And I imagine they will form part of that as that comes out. The other bit around the app, I think the thing with digitalisation is, you're right. Even people who are digitally enabled, actually, like you say, eyesight goes. They can't actually. The screen's too small on a phone and that kind of stuff. So I'm not expecting them to. I don't think it's a one size fits all in this space. And that's actually part of neighbourhood teams. As people become more vulnerable, that we understand the patient, you understand who they are, and you can. There's other methods. It's not everyone must go down the app side. Because actually the app at the moment, you wouldn't go everything down that side anyway. But there is a need to be aware of that, because you haven't got the smart technology, not everyone's got that, or kind of digitally literacy to do the same at the same time. So we have to be aware of that, and I think part of the key for the development of plans, as part of the next item on the role of the ICB, is how we engage with our population to help shape those plans as we go forward, to make sure we take all the kind of needs of our local population on board as we kind of develop future health services.
Yeah, that's great. Okay, so I appreciate you're not the government spokesman, so apologies if I inferred you were. So two things. Productivity. I was aware of this 2% year-on-year productivity gain, but apparently in LLR we've actually gone down, according to the data I saw previous from something else recently. So that's somewhat concerning. But just coming back to this thing about the ICB, so obviously I've seen the media statement from the people to say that the ICB is kind of working together with the Northamptonshire ICB, but I see in the slide that it actually says, I can't remember which one it is now because my slides aren't moving, unfortunately on the screen, as a technology failure. In one of the slides, it says that the new strategic mayor will be the representative on the ICB board. So if this, theoretically speaking, if the ICB for LLR and the ICB for Northamptonshire moves together in the way that it appears they are, does that mean that we're only going to have one, that we'll have a strategic mayor that is across, given that we haven't actually had the outcome of LGR for LLR yet, is that sort of hinting that there's going to be a strategic mayor across the ICB for Leicester, Leicestershire, Rutland and Northamptonshire? Is that what this slide is suggesting? Thank you.
No, that's what the government policy, that's what the intent of the document is in terms of having that role on the ICB. But the reason actually, as we get to the next item, that we're clustering and not merging is exactly, we need to wait and see what happens in the white paper around local government reform and then reflect that once. And so that's part of the reason it's a clustering, not a merge.
We can stop panicking. No, one strategic mayor for both counties would be deeply exciting, wouldn't it? Anyway, Mr. Bools.
Thank you very much, Chair. I'm glad to hear that there's not much new for Leicestershire in here, because I know that we have clinical nurse specialists already who are basically nurse consultants. They run their own clinics. They are in charge of their own patients. They do an amazing job. I know from my own part of the world that we have conjoined GP practices offering shared services, which is, I guess, my frustration with this. There isn't a lot new. And when you talk about savings, the only way to save money in the NHS is to reduce service, because the biggest cost, I guess, is staff. And that's really my question. The only way to make savings in the NHS is to reduce readmissions. So that's to improve the funding we get as a county council to provide proper social care and conjoined social care that actually makes sense when people are discharged, and to reduce service and reduce headcount. Now, I trained as a nurse 15 years ago. Every single person on my course got a job with their final placement. That's generally how nursing works. You do your training, you get assigned to a trust, and they take you on. Now, the reason I say that is because I guarantee if you went to any ward, I've still got friends who are nurses, those wards would fall down flat without nurses from outside of the UK, because there isn't the headcount within the NHS. There aren't training enough nurses within the UK to support the amount of people we need on the wards, and there's still a dearth of staff. You'll get wards I know right now which are understaffed and are stretched. So I just want to correct that, because I think that's a misdemeanor, that we don't need this support, because it's not true, and I hope you can back that up. But my question again is, how can you make these savings without reducing service? Because I don't think that's possible.
Yeah, so I should have said on the workforce piece previously, the intent is to reduce that, but it requires, and it comes from not from local NHS, but from the deanery in terms of what kind of how many places they book at university, how many people can actually get trained in any one time, and it takes a number of years to roll that through. So you're right, there are shortages on stuff, and that's why there's still a pull on overseas recruitment. But the aim, I think, the intent is to offer more training places, so actually that pull's less needed in that sense going forward. So yeah, so I think the key in terms of shifting costs and reducing costs, not about shift service, but actually, as with most stuff, if stuff that happens in an unplanned way always costs more, because obviously you haven't worked it through, and same in simple term, your boiler blows up, suddenly it's going to cost you more to replace it. If you keep it serviced regularly, you're okay in that sense. And the aim of neighbourhood health is to provide that wraparound support to people, so we know we have more understanding of what's happening in that patient's care. We can support them easier, less attendance in the hospital, less admissions, so now the hospital to get back, well, to reduce the size of their footprint, so they're seeing the people they really need to see to, because actually the wider community is looking at health communities, keeping those patients cared for locally in their homes, so they carry on with their lives, but actually we're aware when they might need to escalate, and you can do that in a more planned way, rather than actually if you have everyone turn up in ED, that becomes quite costly, as you'd imagine. And again, I know some of this work's happening already, because you have community prescribers and you have people doing that work already, like conjoining services and making sure that they are staying out of hospital for as long as possible. So I'm just wondering what will be different, because a lot of the initiatives within this either are happening already, as you've alluded to. So I don't see how this will change too much without reducing service, and you didn't rule out reducing service or reducing headcount. And I think that's ultimately where this sadly results in, because I can't see how we can make the savings of the 2% without doing both of those things, you know? Yeah, so if you think about if a patient has a hospital admission, that comes with quite a cost, because you've got the wraparound care on the ward, you've got the beds, you've got the food, you've got that element of it to some extent. If you're treating, if that patient's can actually function in their own lives, in their own home or their place of residence, and actually the people are coming in to see them and keeping them healthy, there's a reduced cost in terms of that. It's not saying there's always going to be a need for hospital, both mental and physical hospital beds that people will need to go into, but it's keeping that, it's like we'd all want to stay out of hospital as long as you possibly can, and as you get older, or as you have more comorbidities, how can actually we care for those patients outside of that setting, so it reduces kind of some of that cost. It's tricky though, because it's not like we're having double running, so you have to set these teams up while the hospital's still got the pressures it's having with people come up to through A&E and then getting admitted, because they haven't had that service in place. So it isn't, I'm not saying it's going to be an easy solution, and you're right, it's not new, it's been identified in a number of plans, and as the Darcy report says, actually the intent's always been to focus on community, but the actual increase in funding isn't in that area at all. So I'm not saying it's going to be, but that's what we've got to do for the NHS to become more sustainable, and that's a collective effort on our behalf to do it.
Mr. Piper.
Thank you, Chair. I've got a number of comments as well as questions to make. And from what you were talking about there, when you were talking there about sickness prevention and unplanned care, I think there's a certain similarity there. And I think to answer your question, Mr. Bulls, is if you can do sickness prevention, then you're going to save costs, just because you're not going to have the number of patients coming through.
To say my point was not that it doesn't happen. My point is it's happening already, and I'm yet to hear too much new, because that prevention work's happening consistently already.
Yeah, well, I think one of the things that Pete said there was about the smoking ban coming in for people under a certain age. Now, whether you agree with that or not, that will reduce the amount of people, and on long term, that must be a benefit. I think one of the things which I've seen in that respect on the social media was a little cartoon about the person that went to A&E when they should have gone to the pharmacy, the person that went to the A&E when they should have gone to the GP, and so on down to the bloke at the end who should have gone to A&E, who died. should have gone to the A&E, but didn't want to trouble anybody. And I think that getting that sort of message across will help you in both the unplanned care, as well as helping not so much the sickness prevention, but getting people going to the right place will make the service more efficient. And add on to that, Councillor King talked about the 16 billion from a software company that may have had another contract, government contract, that went west as well. Maybe it wasn't on your horizon. But I believe also they then sued the British government and won over that contract as well. So the total cost was more than 16 billion. But going on from that, one of the things which has been a pet subject of mine for a long time is the fact that we have an NHS number, we have a hospital number, we have a social security number, we have a driving license number, and we have passport number, as well as whatever else. Surely if we could amortize those 5 into one, that would make life for you long term a lot easier for record keeping. When you're talking about taking care into the community and neighbourhood health hubs, one of the things which I don't think you mentioned was the fact how AI will be able to help you look after patients at home. And from the conversations that we were having on Friday, I still believe that there is a good use for step-down beds and end-of-life beds nearer to people's homes. And although the cottage hospital in Lutterworth isn't a part of this agenda, that will go back to that point there. And I'm sure that Dave in the background is smiling to himself. I think that's coming back to the question, which I think is what I'm supposed to be speaking about, is when we were in this room yesterday, we were talking about childcare moving forward and how the number of schools is the need for more schools in Leicestershire is increasing because of the mobility of people coming in. One of the things that we're looking at the moment is a phenomenal number of new houses in the county. Is that taking part in your 10-year plan? Are you planning more and more hospitals to cater for all these extra people? And I think the other thing is going back to the number of people who are being trained and bringing people in. A local GP told me a couple of years ago that one of the problems is with doctors, there just is not the training places available. And the training places to become a doctor are 10 to 11 times oversubscribed. And I think a minister by the name of Hunt said he was going to cure that problem, but I'm not quite sure that he's did a very good job of it.
Like I say, training places are done on a regional, national basis. They're not a local piece in terms of that, having the places come through in that one. So a few points there. So nationally, they look at the demographics and growth and population, and that's how that's how you get a growth in the NHS budget, and they then allocate that out to each local system in terms of that. So they take that into account in terms of changing demographic growth, and all the information goes into the national team as they do that. But locally, as there are new developments, our strategic estates team link in with the developers and the local authorities in terms of how can we use the ability to get money out to developers to build GP practice or services we need. That isn't always straightforward, but that is a process we go through, and we have been successful in getting more money from those developers to help fund kind of infrastructure needs that the local community will need in that space. So it is something we do, and as housing developments grow, it's not straightforward because it requires how quickly the housing development grows and how quickly you can get the 106 money come through. But that is something we work proactive in terms of doing that. as we go forward. In terms of AI, so the ability in terms of the direction of travel is most people will have their own bed. So they have their own bed in their kind of main place of residence, and actually having rehabilitation in your own where you're going to spend your life is proven to be more successful than having it somewhere else and then coming back to the place where you spend your life. So a friend of mine who suffered from a stroke, his rehabilitation took place in his home, because you have to respond to how your home is set up and actually what you need to do to kind of navigate and spend your life in that respect. So that's why it's that step into a patient's home. But the AI around that can help keep them safe, can track kind of their kind of blood pressure, their heart rhythms, that kind of depend on the kind of need. And also that's a developing area. That's why, and then it can flag to clinical teams actually if that patient needs to be seen urgently. So there is that ability to use AI in that respect.
Going back to the number of hospital places, one of the things that we discussed the other day was the fact that the population in Leicestershire was growing at the cost of other parts of the country. So it wasn't just the population across the country growing, it was mobility of people within the country. And if you're talking to developers and getting the money from the 106, which the 106 money doesn't start being paid out until the houses are built, then if you then have got the money to start building the houses, you're going to be behind the curve by a good few years.
Yeah, we have to work within the rules of the 106 allocation in terms of how those houses develop and how we bring the funding in. The key is that we are proactive in trying to do that within the rules of the game that we have to work with.
Wasn't that many years ago that health didn't even have a look at 106, so things have got to the better. As James, you wanted to have another go, and then we'll move on to the next item.
Thank you. Yeah, I'll try and keep the questions short. It's from colleagues have talked about doctor training places, but also nurse training places before. It's something that I've not done myself, but my now wife, before we were married, tried to get a training place at a number of universities, couldn't get in despite a background as a carer. And so I remember distinctly how hard it was for her and many others that wanted to get on the course then to actually do it. My wife now works in finance, even though she would have made a very fine nurse. My question then is this: to what's the barrier there? Is it capacity for the universities to actually take people, so they're just at capacity to actually teach them? Is it government funding or something else that's actually blocking the amount of people coming through that want to come through to work as health professionals?
So it's the funding to fund the places, how much funding goes into the places to free them up. But also, even when you try and do that, you do need the university infrastructure, the people to do the lectures, to be able to train the people up to go through their degree course and all the rest of it to do it. So it isn't a quick win. You can't just say, well, actually, you can have double the amount of people come through your university course, because you need the staff there to train them up. So it needs a longer term piece. There is a workforce plan that's going to come out on the back of this, the 10-year plan, and that we're looking to how that's going to happen. It should be part of how you're going to kind of grow the numbers and grow the special. It's not just about the numbers, but it's also about having the specialisms as well and how you have the staff to train them.
Mrs. Knight.
I think the content is great, and the benefits and efficiency savings will be fantastic. But it states there's going to be 250 to 300 new neighbourhood health centres by the end of this plan, which is 10 years, and 40 to 50 over the course of this Parliament, which is 4 years. That sounds very slow to reap benefits and efficiencies that are coming in this document.
Yes, so they're the government numbers. They form part of the policy. They're not coming from our side. There's clearly a need to mobilise the centres, but we do have a lot of health facilities anyway. So it's not about just building new buildings, but how do we utilise our current estate and make sure they're fit to become neighbourhood health hubs. In that sense, clearly there will be some capital works that needs to be done, so they will require the allocation to come down from government and NHS England to enable that to happen. But that's the figure they put in. But we do have a range of state talking about the Lutterworth hospital, for example. How do you use that in a new way to provide a neighbourhood health hub in that local area, for example, would be one way, rather than just having a new facility built there. Utilising our current ones that we currently have, and some of it is around actually it's helpful to have hubs, but it's also helpful to have our teams go and see people in their own homes, actually, because they're out and about and saves the patient having to come in the first place where that's well.
So for Leicestershire, have we got a good spread across the county?
So we haven't got, in terms of what depends on what they expect to see in neighbourhood health hubs, but we have got a good spread of estates across the council. Is it all fit for purpose for the need we need in the future? Probably not entirely, but that's why we need the money to flow through to make that change. But certainly we don't need to start building lots and lots of new buildings. We have a range of buildings we could utilise.
Okay, let's move on to the next item, which is it is kind of linked, to be honest, but it's more about what's happening locally. And these things are going to run and run, because as plans develop, more detail will come out about what it does actually mean for us more locally, which I guess is what most of us are interested in, to be quite honest. So Pete, do you want to talk to the next one?
Yeah, so next, this item comes out the 10-year plan. So the 10-year plan identified kind of restructuring reform in the NHS. So you've heard the announcement, NHS singing by 2027 would have disappeared. It'd be merged into Department of Health and Social Care. Health Watch will cease to exist from 2027 onwards, unfortunately. CSUs, the Commission Support Units, support ICBs currently also no longer exist going forward. And one of the other ones was around ICBs and the role of the ICBs and the size of ICBs. And that's kind of, that came out of the 10-year, okay, actually got announced before the 10-year plan was launched, but that's what this item's around, and that's kind of the background in terms of that the government's intent to reduce kind of management costs within the NHS. And so there's more focus on patient care as you go forward. So when they announced that, what it requires is globally an NHS reduction in ICB's cost of 50%, slightly different, and I'll talk about slightly different. It's in Northampton and LR, but as an average, it's 50% reduction in their costs. So therefore, to achieve that reduction, there's a need to look at our kind of staff base. It also articulates the future role of an ICB to be around strategic commissioning, focus on patient outcomes, focus on kind of delivering long-term change to health services that will improve the outcomes of our population and that kind of piece. So as we went through this process, some ICBs are quite large. So Manchester, they're staying the same kind of footprints, but they're obviously reducing their headcount or aiming to reduce their headcount. Within the East Midlands and the Midlands, actually ICBs look to how they can either merge or cluster together, and the clustering is partly related to the fact that local government reform in not all areas has happened, and therefore you want to see what happens in that space before you merge. So that's happened up and down the country, and that's been agreed in terms of there'll be 26 new organisations, either a cluster or consistent organisations that will move forward, and anything that's approved the clustering of LLR's ICB with Northamptonshire's ICB. So that's the kind of work we're moving forward with at the moment in time. Aim of that really is to reduce some of the management costs. So a single board across both organisations, single chair, single chief exec, single executive leadership team with a single governance underneath to kind of streamline the processes across both areas. And that's what we're going through at the moment in time. They're still waiting on announcements and then slide decks. They've gone through a recruitment process for the new chairs and chief execs. Actually, the chair was announced. We've got Anil Singh, who's the chair in the Black Country ICB at the moment. She's coming across to become the chair of the new clustering organisations. We're waiting for the formal announcements on the chief exec post, which we expect sometime soon. Now the chair announcements have been made going forward, but that's how we're looking to move forward. And our focus is around what's our role, how our role changes to be focused on street commission and patient outcomes away from some of the work we do at the moment in time. And that really looking at patient data, understanding the local context, developing long-term plans for population health, then kind of delivering them and evaluating how successful they are as they go through. So that's the model ICB is requiring. I said it's a 50% cut across the country. Across Northampton and LR, slightly different. So in LR, it equates to a 33% cut, because actually the actual ICB's footprint or cost footprint was less than, say, other areas in the country, and in Northampton it's 29%. So actually, we got less far to go than others, but it's still going to be challenging as we kind of reduce that. And the core of that is staff. That our core cost is staff, so that will see a reduction in staff. But as also we'll see a reduction in some of the functions that we do. So some of the functions that we currently do is indicate that they'll move into other organisations. So into NHS England or into the provider setting as we go through. But although the blueprint that was published recently, they are reviewing some of how those functions might work. For an example, it requested that emergency planning and preparedness would move into NHS England. I think they're now realising that might be more sensible to remain in the ICB as we go forward. Implications, our aim still is focused on patients, still focused on, and they have been the key priority in this, and working with partners in terms of delivering those outcomes as we go forward. So that element hasn't changed. It's really in terms of our focus on strategic outcomes. But we'll be looking obviously patient flows, continue with our partnership work, continue the neighbourhood. So it doesn't change the neighbourhood configuration that we've worked up within LLR. That will maintain. In Northampton, I'm sure we've got 2 neighbourhoods as well, so we'll continue down that route at the same time. The initial aim was to have the reduction in staff happen by end of December this year. That hasn't happened because there isn't the funding to allow for the redundancies to take place currently. So that's going to be on a longer term time scale, but we don't know realistically because we haven't got the money to make the changes. But that will need to be worked through as we go forward. I'm happy to take any questions.
Thank you. It may solve some cross-border problems in my part of the world, which would be useful. Any questions, Mr. Bowles?
Thank you very much. There was an item last meeting as well around some of the transitions. I've got 2 questions. The first one is there's already health inequalities when it comes to Leicester as a whole, between Leicester and the county where I am represent. That's on health outcomes and inequality, but also in provision of service. So the access to diagnostic, the access to clinics, for example. By expanding that geographical area, are we going to be in danger of accentuating those inequalities because we're making it more remote potentially from decision making in some of these areas when you double the size of the geography? And the second question is, you mentioned there about maybe handing certain services over. I know this isn't probably your problem in some respects, but how are those other bodies meant to fund it when there's no funding available to those people already? So if some of those functions came to the county, for example, we're not expecting any boost in money. We've already running a deficit as a county. So how are we meant to take on those services when there's no extra budget coming our way to do that? And that again feels a hole in this plan.
Yeah, so I can't. So on the first bit around the money, yeah, so we have to reduce. So we can't even say, right, here's the service, it costs X, we move that across and that's the savings to the ICB. We have to make the reduction in staff before that moves across. So the key to that is working with our partners in line with kind of the direction we've been told to go down, and how do you make that work so it's safe and actually achievable in that sense. That's a key relationship in terms of doing that. They are reviewing some of these functions that they had indicated could be shifted across nationally. So we need to see the outcome of that review and how we work that through. But it's going to happen over time. But it isn't just, like you say, if you're any organisation, you don't just accept it. You need to understand what the legal requirements are and how you're going to fulfil the function of that service as it moves across to some extent. So we need to work in partnership to do that, and that's going to be key as we go forward. Sorry, what was your our health inequalities. So yes, it is a bigger footprint, but one of our legal duties is to support and address health inequalities, and we'll continue to work with our DPHs in terms of their role in the neighbourhood health. We've got a health inequalities team that will then look at the data across the patch. There is a danger as you shrink a team's workforce, but and then spread it further, that some of that gets lost. But the intent of an ICB is to be focused on strategic outcomes and the outcomes for patient population, and actually we need to be focused on, okay, what are the outcomes then? Where are they worse? How do we address them in that sense? And that relies to kind of service provision and some of the services we put into those spaces. So there is a risk there in terms of how we go through, but the intent is to make sure actually that's what we are addressing as we move forward.
Mr. King.
Yeah. So I've seen this stuff about this. So there's 2 things I wanted to say. First of all, Chair. So first of all, I can see that you're going around all the different health and scrutiny committees at all the different councils across LLR. But Chair, I think that then necessitates we ought to have had a joint HOST meeting to consider this item. instead of it being salami sliced across all the individual ones, and we could do that as well. But I do think there should be a joint HOSC meeting. There isn't one scheduled as far as I know, but I think this sort of item, given the significance of it, it ought to perhaps be coming there. But that be it may, just something you just mentioned earlier, Pete, is you said that Anis Singh, who's the chair of the ICB at the Black Country, has been appointed the chair of the cluster, as you call it, for Northamptonshire and Leicestershire and Rutland ICB. Is that right? Is that what you said?
Yes, that was great. That was
right. Okay.
Yesterday.
So that then concerns me a little bit, Chair. That I don't know anything about this lady. I'm sure she, government's decided she must be competent. There's obviously been a recruitment process, but given that she's been leading the Black Country, which that's the West Midlands and even further past, it's the other side of Birmingham. That then concerns me that we've then got someone coming from over there to. I mean, okay, maybe she's got a lot of knowledge. I don't know, so forgive me. I haven't got all that information, so it's kind of hard. But I'm just trying to understand what her knowledge is going to be that's relevant to our area. In order, or is it just she's been? I mean, so therefore. That's a bit of a concern, that I've got. Talking about governance and accountability here. So the governance and accountability is the NHS, as you said earlier, spends an awful, or your presentation said rather, spends 38% of government expenditure. That's a lot of money. And what I'm unclear now is the governance and accountability of how this is going to work. So I think that's the concern I've got. The other concern, it goes back to, at the end of the day, what do the taxpayers want? What do the local residents want? What they want to know is that when they need to see a GP, and in your earlier slide, it talked about transformation of family doctors. I forgot to ask that question, but I'd love to know what the future of a family doctor looks like, because if you can actually find one to see, you'd be doing well at the moment. That's what residents tell me. So that's just a fact. So I think the concern I've got is what is this, changing all the administration of everything and bringing in new people and all that. That's great, because I'm sure that's, sounds a bit like a regional health authority and all but name to me. But, that's great. But what does it look like at the grass, on the ground? Picking up Mr. Bull's comments, and you did mention nurse prescribers earlier, and I'll have to declare that my sister is the chair of the Association of Nurse Prescribers nationally, so just as a fact. So I know a little bit about this, unfortunately. And so what I'm concerned is, what does it look like on the ground, and what does it mean for waiting lists? What does it mean for access to outpatient care? What does it mean to access for scans and because ultimately that's what this is about. And we could go to, I'm sure as colleagues have all got examples of where either they or people they know have been told, oh, we'll refer you in for this. Oh, by the way, it's a 6-month wait. Well, I've got a personal example of where I've got a family member in Leicestershire who is referred for treatment last year, and is now only a few days ago being told, well, you won't get seen until next year for an appointment. That's by my reckoning, that's 2 years from referral by GP to actually getting seen by a clinician. Now, I don't think, for apparently a non-urgent issue, but I think that's an exceedingly long time to be sat waiting. So what patients want to know is, whatever we're doing here, is that going to make a difference to that sort of problem and that sort of issue? Because that's how they measure the success of this reorganisation, this restructuring. They don't really care who's doing it in some respects. All they want to know is, when they need to be seen, are they going to be seen quickly, or are they going to have to wait a month, 2 months, 12 months, 24 months, goodness knows how long? That's what they want to know. And I think that's what I'm not really sensing from this, is what difference is it, it's the so what. What difference is this going to make ultimately to patient care and patient outcomes? Because that's what we all want to know. And that's what this is not telling us. Thank you.
Yeah, I'll start again with a similar comment last time. It's government policy. I'm not here to defend government policy about restructure and that kind of thing. When they announced the policy, though, the aim of restructuring ICB's NHS England and reducing the footprint was to free up money so it goes into frontline resources. That was the announcement they made as a government in terms of the direction of travel in that sense. So that's what the intent is in terms of reducing the cost of the ICBs, reducing the cost of NHS England to free up that resource into frontline stuff. I'm also not here to, I can't, in terms of answer questions about waiting, the long waiting list, that's not my agenda. They're better people, better qualified to answer in that respect in terms of do that. And but the 10-year policy, the previous item was around how you shift activity, the neighbourhood health teams, the use of AI, that kind of stuff. Digitalisation, the NHS was meant to make it more productive and streamlined in that sense. And that's what the previous item was. This item is around the restructure of the ICB, in line with the kind of direction we're given from NHS England in terms of having to reduce our footprint, cluster and that kind of piece. And then there was a question then in terms of the new chair coming in terms of the role and their kind of ability. So for starters, I've not met our new chair, but she has a raft of experience in both local authority and NHS at director level. And has been obviously a chair of another ICB, so she comes with the skills and understanding of the sector and what's needed. And some new into LLR. I previously worked in Lincolnshire for 5 years in a similar role. It is different, but the context is the same. But the role of the chair and the non-execs is to hold us as executives and our chief exec to account for the delivery, and we're the ones with the teams, delivery teams, who have a kind of the raft of knowledge locally in terms of doing that. So our chair, and obviously they've gone through an NHS England process to be recruited, clearly has been seen as being a good accountable person to that role, and will be able to do the role of the chair. Yeah, as with anyone joining a new system, they're like, you do need to learn and get out and meet people, but that is the easiest bit to do rather than having the skill sets to do the job, and I'm sure the process has avoided that being a problem.
Yeah, thank you. And I'll take up with the joint health scrutiny is currently administered by the city. So what goes on the agenda is mostly in their gift, but we are having an agenda planning meeting in October because we're not meeting terribly often. I will raise it with them there. If you, and don't be besmirch the Black Country because I'm from there.
If I may, Chair, I'm not besmirching it because I've my mother-in-law's from there as well. But just coming back to what you've just said, Pete. Now in the slide it says that the priorities to provide high quality care and reduce waits, whatever that wait is for. That's my point. So how is this going to help improve that? That's in the slide.
So the role of the ICB is, but it is the previous item. So the 10-year plan comes out, how the ICB, I know, but the item in terms of how they are related, because the 10-year plan talks around the restructure NHS and the reform of the ICB, Health Watch, NHS England and that kind of piece. The new role of the ICB is to ensure that delivery of that 10-year plan happens. The aim of the 10-year plan is to reduce kind of waits, make sure people are getting rapid access to services using the IA and all the other pieces that as long as we're doing the preventative stuff, so they actually don't need the care in the first bit. So that's why they are related. So the role of the ICB is to ensure the delivery of that 10-year plan, working with its partners, both in the NHS and the wider local authority and voluntary sector and care sector.
We will wait with interest, I think is a polite phrase there. Hardik, you wanted to come in.
Yes, thank you. It's just a clarification point, actually. Pete, you mentioned that Health Watch will cease to exist in 2027. Although there has been that date somewhere along the line and ICB have picked it up, we have spoken to ICB because that's not accurate. We don't have any timescales for when or what will happen in terms of legislation changing. So I just wanted that to be noted. And we're continuing to work closely with yourselves around the NHS transformation and engaging and having the patient voice and patient experience. But I just wondered if that could be taken out of any information that has been circulated, mainly because County Council and the City Council are our funders and our commissioners, and they don't have any information on timescales or dates. So 2027 isn't confirmed. So wanted to flag that up, please. Thank you.
Okay, thank you very much. Again, we'll see what the legislation says when it turns up. I think we're done with that. So thank you very much for your time, Peter. And yeah, it's something to watch because if it doesn't work, it's only going to be more of the same, which I think somebody said earlier, which I think is our biggest fear, to be quite honest, that both items rolled together don't make the change that we all like to see. So thank you. And we will move on to the Winter Plan 25-26. We've got Professor Nils Sangagi and Sarah Smith to come and talk to us about this matter. Oh, and a couple of other people got on my list.
Hi, good afternoon, Chair. I'm Neil Sangani, Chief Medical Officer for the ICB, and I've got with me on my right.
Good afternoon, I'm Sarah Smith, Head of Urgent and Emergency Care for the ICB.
Hi, I'm Jean Knight, I'm the Managing Director for Leicestershire Partnership Trust and one of the SROs for the UEC programme.
Good afternoon, I'm Sarah Taylor, I'm the Deputy Chief Operating Officer at UHL.
Gosh, well, carry on. We've got a load of slides here. You're not going to take us all through.
No, we're not, and we're conscious of time after a long discussion there, and I think there's some overlap possibly between some discussion that's been had, but we have an annual responsibility as a healthcare system to plan for winter for obvious reasons. We need to make sure we can manage the pressures that we see during the winter and deal with any surges that we might experience. So hopefully within the slide deck, you've seen the comprehensive process that we go through. So this is a collaborative engagement process with all partners, so primary care, our hospital colleagues, social care, everybody, and working together to do that. We've got lots of learning from previous years that we build on year to year, and we're making some significant improvement in our urgent emergency care pathway to improve the access, the outcomes and experience for our patients. It's still a challenge, it will always be a challenge, and you've often heard me talk in these fora before about actually how winter pressures are annual pressures now, so we see challenges all around the year now, increasing numbers of patients with long-term conditions and complexity. What I also just want to draw out in the plan, if I may, Chair, is the vaccination strategy, and really also to ask for your help with the population to improve our levels of vaccination uptake. Really fundamental for us. We've got some really good rates in the county actually in terms of vaccination, but one of the key drivers of our increased demand and surge over the winter period is respiratory illness, so flu, COVID and such like. So getting our social care, our healthcare staff, as well as our population groups very well vaccinated with a range of vaccines out there is really important. I'm just going to hand over to Sarah to give a little bit more detail on the plan, and then we're happy, colleagues, to take any questions on the detail to the plan. Thank you.
Thank you. So this year NHS England have taken a slightly different approach in that, so far as they've asked us for a lot more detail. They have asked us to model our plans this year on a level of scenarios, those being business as usual, so what we see for the first half of the year, April through September. And then what they call surge and super surge. So surge, they are considering anything that's impacted by an increase in flu, COVID and RSV. And for super surge, basically how the system would cope across health and care if we saw an increase in respiratory illness, workforce challenges, because of course our staff get ill as well as our patients, and infection prevention and control outbreaks. So we've done a lot more detailed modelling. They've asked us for a lot of data, and for the first time we've been asked to do a number of tests of our plan this year. So for LLR Health and Care, we have an internal testing process next Thursday, the 11th of September, and then all of the Midlands ICBs will come together at a regional stress testing event, as NHS England have called it, on the 17th of September. At the same time, there are concurrent trust plans being developed at UHL and LPT level, and they are going through their boards on the 11th and 9th of September, respectively. The narrative has been developed via each of the working groups that we have across the urgent and emergency care governance process, and that's also where the wider engagement has happened through the working groups and their broader partnership membership. Thank you.
Okay, thank you. Questions from the committee? Comments? I mean, one thing I thought of is back in the day, 1,000 years ago, you used to actually have spare wards kicking around at the Royal, and they would be specifically brought out for winter use. Has that disappeared now? We just got all the beds in use all the time.
I'll let Sarah answer that, but I just want to reference the context in which we're operating now. So as Pete described earlier on, we are trying wherever possible to do that shift from hospital to community care. So wherever we possibly can, we know it's more cost effective, more productive and more efficient to offer care in the community where it's clinically appropriate to do so. We are a system that's in a significant financial challenge. Hospital beds are very expensive, so we do have to also make sure that the right people are in those beds to give that care. But I'll let Sarah comment on our capacity over winter this year to open beds where we need them.
So we don't have any spare capacity at Leicester Royal Infirmary. It is literally chock-a-block. What we are doing this year as part of our acute community plan is we will be, for winter, utilising a community location called Preston Lodge. So we have the ability to open the first floor of that, and we're planning to do that from December to support winter pressures. What we do know is that at Leicester General there is opportunity. So if we were in a position, noting the financial position, whereby we go into a super surge, as Sarah's just described with the modelling, then there is some flexible ability to do that. But the LRI is completely full.
Okay, thank you, Mr. Poland.
Thank you. You talked about sort of respiratory illnesses being the big effect, and you mentioned flu and COVID and so forth in that. Are we noticing, has COVID made the situation worse over the winter, since obviously we were on lockdown in 2020 and 2021, and obviously we haven't had that since, thankfully, but of course it's not gone away. So is it still a distinct issue as opposed to flu? Or is it all sort of grouped together now in the one sort of category?
Yeah, it absolutely is. So we aren't testing the way we used to. So it's actually hard for people to know sometimes if they've got COVID or not. So a lot of people will be getting COVID and not realising. But particularly for our frail, vulnerable populations, those with long-term conditions, respiratory disease, cardiac disease, diabetes, so on and so forth, learning disability, when they get COVID, the consequences are more significant. So if you are in one of those at-risk groups that is eligible for vaccination, that's because you're at higher risk of being hospitalised, not just being poorly with COVID, but being hospitalised through it. So that was my point about drawing out the vaccination strategy, which is actually written very large in our winter plan, because we know that this is where the prevention agenda, as Pete was describing earlier on, comes in. If we can vaccinate that cohort of population who are high risk, even if they get COVID with the vaccination, they're far less likely to be hospitalised, end up in Sarah's A&E department, or be admitted into the hospital. So really fundamental promise. Same issue with flu. And we get the cycles, and we're watching what happens in the Southern Hemisphere at this very point in time, because that then predicts what will happen for us this winter in our hemisphere. So vaccination is absolutely key to those vulnerable groups, and we encourage all those with their long-term health conditions to make sure they get booked in for their vaccination via their GP surgery, their pharmacy and other outlets that we have.
Thank you. And you mentioned, obviously, if we know the importance of vaccination, is take-up of vaccination from the groups that get offered it good in LLR? Is that something we want to see? And if not, is there anything sort of more we can do to sort of increase that? And am I right in saying that children are also in the vaccination sort of categories? I have two children of school age. And again, what's the sort of take up there? Because I know from my own experience, and I appreciate it's one example, but we get a form as parents saying, will you vaccinate your children? We go, absolutely, yes, do it. And then invariably, he's year 5 now, and I think I've had it for 4 of the 5 years. You get a thing go, yeah, well, he said he doesn't want it, so he's not got it. And it's like, well, why did you ask then? You know, he's year 5, so he's still primary. So I wonder to what extent the children can just say, I don't want it, even if parents are saying, please give my children.
Yeah, so you'll see in the data on slide 64 of the pack that actually the county does pretty well actually in our high-risk groups. We have some further challenges in the city in particular, but the county does very well if you benchmark as East Midlands the national standards. The groups that you've actually highlighted, so children are an issue for us. The flu vaccination is only available to preschool children as a routine, and those children who are in a disease group, so asthma, diabetes, or some other high-risk group like immunosuppression. So absolutely we go on parents consenting for preschool children, but if a child is not willing to be vaccinated or is putting up a resistance to it, then healthcare workers have to make a decision on that. But we use parental consent for child vaccination, particularly in the preschool groups. Just want to also draw out, though, really relevant for county council staff, is that the social care staff, frontline social care staff, our vaccination rates are low. Our vaccination rates are low in healthcare staff. This is really important for us in winter. We need our social care staff and our healthcare staff to be fit and well, and also not to be passing on the disease to their patients and to their clients. So anything county council colleagues can do to support with frontline social care staff really helpful for us to keep the system running effectively during the winter.
Thank you. We'll move on. Oh, Mike wants to come in.
So just to reassure committee, picking up on Neil's points, actually we did recently take a paper to our corporate management team doing the usual kind of influenza season, which does involve doing clinics and vouchers and pushing social care staff and indeed all our staff within the county council to do that. But as always, you can lead a horse to water, but there's an increasing kind of, I don't know, the rates have dropped off, shall we say, since COVID. There's a number of reasons why that, but at least the offer's there.
I've got quite a few speakers. Hardip next.
Oh, hello there. So Neil, you mentioned discharge, and Healthwatch are currently working with UHL on the hospital discharge survey, which is actually coming to an end at this month. So I've had a quick look at the results, and there is quite a bit about safe discharge. So I just wanted to flag that with you, actually, that I guess what we're hearing from the public and patient experiences around discharge and concerns around the safety of discharge. So flagging that for you while I've got the opportunity. Thank you.
Yeah, it's a really important point. Obviously, we know that there's, again, coming back to the points earlier on made about efficiency and cuts, actually discharge is one of our best areas for improvement to make efficiency in the healthcare system overall, but we want to do that safely all the time. So I'll pass to Sarah just to emphasise the mechanisms that we have in place to make discharge really safe. But one thing I'd just like to emphasise, and it comes back to the digital conversation earlier on, is about virtual wards. So one of the mechanisms that we have to discharge somebody safely is to discharge them to a virtual ward. So they continue to get monitoring, remote monitoring and input from our teams so that they can go home that little bit earlier than planned in a safe way. And if they're not doing very well or there is a deterioration in their clinical condition, we can pick that up and respond to that effectively. But Sarah, do you want to comment on our processes for safe discharge?
Thank you, Neil. I think it's fair to say it's an area where there are always things that we can improve on. There's always things that we can do and areas where we need to learn from the experiences of our patients. So we split it into those simple discharges that will leave the hospital, which is broadly around 90% of the discharges that do not need any form of support. So they're going home to their own environment and with the family relatives maybe taking them or by their own self-esteem. The ward process work that's being undertaken at the moment is about making sure that they have the right information, that they are aware of who they can contact if they need further advice, that they can get through to the ward. And we need to make sure that when a patient needs that access, that of course somebody is there to answer the phone and to give them that advice, which is challenging on a busy ward with sometimes a limited number of nurses. So as I say, always more to do there. Then there's those patients who need to go home with a varying degree support package in place, or even to a placement not of their own home, so be that a community hospital or be that a residential or a nursing home placement. Our responsibility then becomes about making sure that the transfer of information is timely, accurate, and covers the basic all the basic requirements that patient will need. Again, I would say that there's more for us to do there. We need to make sure that that information is robust, that patients go with the required amount of medication, and the discharge improvement is absolutely focused on that as well.
Thank you, Mr. King.
Yeah, thanks. So look, I think there's a number of things here. So it's good to hear you're planning things and looking at different scenarios. Surge and Surge Plus, whatever that means. I suppose it means you're super busy or you're just impossibly busy. And I think I've experienced all those in situations with a family member. Certainly the extra surge, I don't think anyone wants to experience that, whether you're a patient or you're a member of staff. But just coming back to some of the issues. So one of the biggest problems that you do have, particularly down at the Royal, is ambulance wait times. I mean, we spaffed a lot of money on that to try and sort it out. That's not worked. So you've still got a huge problem, and you have a marquee outside or whatever it's called now to try and sort that out. But that doesn't seem to work terribly well either. So whatever you're doing, do you think this is going to work this year, and that no one's going to have to wait an excessive amount of time out in the car park or in the tent, or whatever. As I say, it's not a tent, I know that, but it feels a bit like it. And having experienced that, I wouldn't wish that on anyone, because it's not a pleasant experience. I know you do your best, but it's not particularly the most comforting. But then the other thing is, you talk about in this about this year you used I think it's Loughborough Community Hospital for more X-rays. Well, that's great, but we have other community hospitals that have X-ray equipment that could be used, and I just mentioned Market Harborough. That's not mentioned here, so I'm just wondering if this is all going to be factored in. And finally, okay, the vaccination rates, but just picking up what Mike Sandy said. I mean, going back in the day, there used to be people who actually went and did workplace vaccination sessions for employees, and you'd have a day when you could get your vaccination. I don't know if we do that at County, Mike, where the actual medical team come in and actually do that. But that to me would make sense if where we know there's a lot of employees, we can actually offer a day and say, right, if on X day you can turn up and you can get your jab. But one of the problems I know locally down in South Leicestershire is when the vaccines, when it is in the vaccine season, and people, obviously they don't all go to the doctors to get it done, people go to the chemists and all that sort of stuff, and I've done that in the past and it works really well. But then you get a situation where they run out of stock, and then they say, oh, we haven't got any more stock coming in, and then by the time you get it, you're kind of thinking, well, it's nearly the end of the season, should I have, so it's kind of, there seems to be a problem with supply of the actual vaccinations at time for some of the outlets who are actually offering vaccinations. So what's been done to kind of improve the or smooth the supply of vaccines, so we don't have these kind of outages where there isn't any vaccine, and people, because obviously if they're motivated to go and then they suddenly find, oh, I can't get it done, it kind of puts them off, and then they kind of they go and do something else and they kind of forget about it, don't they? So I'm just wondering what you're doing to address that. And finally, what concerns me, the other thing is, in all these things, is the knock-on effect on other clinics, and particularly people who are already waiting excessive amounts of time to be seen, and whether that's going to have yet again a negative effect on the waiting times that people are having to wait to be seen by clinicians or in clinics, or to get scans and all of that stuff, because of the increased activity brought about by surge or super surge. And so what's then going to be in place to kind of make sure that those people who have been waiting are going to be kind of, don't lose out, basically, and put it in common thing. And the only other point I wanted to make, Chair, is that I have noticed myself that since, and Mike mentioned it, since the kind of unwind from the pandemic situation 5 years ago, I have noticed that personal hygiene, I'm not saying in the NHS, but just across the board, I think personal hygiene has dropped off for a lot of people. I mean, hand washing and things like that, and people are not doing it as much as they were. People had got it into their heads, wash your hands all the time, blah, blah, blah. I don't think that's happening. And I think there's something in that, and whether that's just something locally, or whether that's something you can feed back to NHS nationally and say, what are they going to do about that? Whether they're going to have a national campaign about that, I don't know. Thank you.
Okay, so I think I'll work backwards, if I may, on that. So if I pick up the vaccination strategy first, so we have a really comprehensive vaccination strategy, most of it outlined within this paper. We want to have as many different outlets as possible of vaccination. So all our GP surgeries, we have something called an enhanced access, which runs up until in the evenings and on every Saturday in all of our primary care networks. So we try and make sure we don't have the pressure on the daytime surgeries wherever possible, so it doesn't do that bit that you said in terms of knock-on effect to clinics. We have a lot of healthcare assistants and health support care workers trained to vaccinate. So again, it's not taking our doctors, our nurses, our pharmacists away from vaccination in the main, so that we can keep the service running. The infection control bit, personal hygiene, we're not responsible for everybody's personal hygiene as an NHS, but we do take infection control strategies in our organisation, so in our hospitals and our GP surgeries and our community trusts, where the levels of flu and COVID are rising, and we think we need to take different actions. So the mask wearing still occurs where necessary. Our staff are all trained to make sure they're washing their hands and using alcohol gel and adhering to strong infection prevention control strategies. And we do encourage patients to actually wear masks when we've got outbreaks of influenza or COVID if the rates get so high. So that is one thing that we still continue to do. In terms of pharmacy and stock planning, so all of our services base their vaccination ordering on last year's uptake plus growth, and we try and anticipate what we need. The issues about stock are usually out with our control. They're usually the manufacturers, the pharmaceutical companies who produce the vaccine. Actually, in recent years, it's been far less of a problem. It was definitely a problem a couple of years ago. It's improved significantly over the last few years. So we have better planning. We also try wherever possible to make sure people are booking appointments for their vaccine so they're not disappointed. So we do have some drop-in clinics, and we try and encourage as well to improve access. But wherever possible, we try and get people to book in for their clinic so we know we've got the vaccine there and we've planned for it. I'm going on to ambulance waits now. We've improved significantly, actually. Really important point. It's still a problem, absolutely still a problem. It's going to be a problem this winter at times. It's not going to be something that we can consistently do, but we have improved significantly. You'll see in the metrics there, we have two key ambulance metrics. One is the response time, really focusing on what we call our category 2 responses, those patients who might be having a heart attack or a stroke, something that doesn't need an ambulance within sort of 8 minutes or whatever, but actually needs an ambulance within half an hour. So we really focus on that. What we're also supporting our ambulance service to do, East Midlands Ambulance Service, is to make sure they are seeing and treating wherever possible. So if it's a case they get out to and they can manage there in situ, they will manage in situ and not convey that patient to the hospital. And also hear and treating. So when they're triaging them on the telephone, if they can tell it doesn't need an ambulance after a clinical assessment, they will pass to one of our services, one of our community services, one of our out-of-hours providers, or whatever that response might need, a mental health service if that's what's required. So we're trying to reduce the number of ambulances that have to be conveyed. There's only those ones that do. We are working this year to a maximum 45-minute ambulance handover target. That's really challenging for us to do consistently all the time when Sarah's A&E department is absolutely exploding, but we absolutely are trying to work towards that. Our challenge this year is consistency. So it's trying to make sure that's happening all the time, day, night, weekend, everywhere we possibly can. And I'll just pass over to Sarah just to complete any further points on the ambulance handover, because it's still a key target for us.
Thank you, Neil. I think Neil's covered the majority of the answer. What I would add is that our plans focus on flow into the hospital, flow through the hospital, flow out of the hospital. So flow in the additional capacity that we are putting into community locations. There is lots of research out there that will tell you that when an emergency department is overcrowded, it becomes efficient because staff have got so much to do that inefficiency causes delays. So we need to try and decongest the emergency department. We are the largest emergency department nationally. We see the most attendances nationally, and we were working together as a system to address that. The flow through the hospital is entirely within our gift to be more productive and to address those delays. And so there's work underway about that. We've already touched on discharge and the discharge improvement group and how they're working across the system. Ambulance handovers isn't a single issue. It's the subject of many issues, but mainly due to exit block.
I would ask Sarah to comment on the X-ray facilities point.
Thank you. So yes, we have a variety of community radiology services across the county. However, where we extend services, patients can reasonably expect to be treated in the same place that they receive that diagnostic test. The reason for expanding the service at Loughborough is because we have a 24 hours a day, 7 days a week urgent treatment centre with an appropriate multidisciplinary team with a skill mix who can manage the patient. So post X-ray, they can either diagnose and treat the patient there, or they can provide temporary support and bring them back for an appointment the next day. So whilst I appreciate it's not ideal, we only have the one other service outside of the city, and it is in the north of the county. That's the rationale for expanding Loughborough at the present time until we can afford to put other services in other places.
Well, thanks for the answers. But, you know, if you're a resident in South Leicestershire currently, you know, coming into the Royal, it's not an easy experience. Going to Loughborough, well, you know, why would you do that? You know, it's just, you've got to have a car. So if you can't drive, you need transport. And that's an incredibly difficult, you know, I don't know, it's well over an hour to get to Loughborough from South Leicestershire. And we have a lot of older residents who live there. So then you get people looking at other facilities like going to Kettering, and I can tell you, I know people here might think the Royal's bad, but Kettering, I mean, I've been there as well, and it's just physically constrained, the whole environment. I mean, it's not because it's poor care or anything like that. I'm not suggesting that for one moment, neither at the Royal, but it's a much smaller facility, as I'm sure you know, and therefore the sheer weight of volume of people. I mean, it's just seeing is believing. So I've seen that as well. So I think it's incredibly difficult, but that's why I'm making the point that I think what does also happen, and this is inevitable because of the mixed access, because you've got multiple points where people can access support and treatment, is there is a degree of confusion about, well, do I go to this place? Do I go to that place? Oh, sod it, I'll go down the Royal. And that's basically almost like a default that people have when you talk to them and say, well, why did you go there? Well, I couldn't work out where I could go. And people say, oh, well, ring 111, and they're not satisfied with the answers when you say that. So I'm only feeding back what residents say to me when I put the points to them, and they say, well, why can't I go there? Why do I have to go such and such a place instead? So I appreciate there's a lot of work being done. I get that, but I do think there are still some things that could be done to improve clarification on where people should go, what they should do. Obviously, an emergency is an emergency, but if it's not, then I think it needs that clarification. Thank you.
Yeah, really good point, and it's absolutely true. It's a complicated system, and there are some particular reasons around estate or ability to house an X-ray facility and timings of service and ability to afford all those services around the whole of the county. We have got something called Get in the Know, which is our LLR campaign to get in the know and understand where you should go. So there's 111, but there's also a simple repository on our ICB website, which advises you when services are open, what's available, whether X-ray facilities are available that patients can use. We still do advise 111 online and via the telephone wherever possible, because what we want to do is try and direct patients to the right place at the right time to see the right clinician, because we don't want that experience of waiting 4 hours in an A&E department when actually you could have gone somewhere closer to you or had a different type of care. And we also want to book patients into urgent care centres wherever possible. So again, not having to sit waiting, if we can book them into an allocated time, it's a much better experience for our patient. We've got a redirection campaign going on at the moment at the A&E front door, and we know that a lot of our patients in the city in particular, for example, but also in the county, go to A&E as a default option, and actually they don't need A&E services. So we've got a redirection campaign to one of our urgent treatment centres to allow them to be seen more quickly in a better environment with near patient testing, including X-ray facilities, so that patients can be seen more quickly, decongests our A&E department. So get in the know, really important, and we'll share that after the meeting so colleagues can share that with your constituents.
I have to say, in sunny Market Harbour, many people just go over the border to Corby, probably incurring massive cost to Leicestershire, because it's so much, if you've got a car, because it's so much simpler, and they're open till 8 o'clock and they treat you, because I know this from a broken wrist. However, and by the way, EMAS are coming next time, so if we've got any EMAS-y questions, save them for them. Mr. Piper.
Thank you, Chair. 1 or 2 comments more than questions, but 1 or 2 questions also. When it comes to vaccinations, pre-COVID, I was seeing an awful number of comments in the various news media strategy streams about the number of people with mumps and rubella and things. And in fact, in some places in university towns in America, they were virtually talking there about a vaccination passport before letting people in, long before it was talked about here with COVID. Did the whole scare over the MMR, do you think that is still putting people off of vaccinations? Also, there was a lot of harum-scarums about the COVID vaccinations. I think that's the first thing. In your page 64 that you mentioned on here, there was a group of people that said healthcare ESR, which I wasn't quite sure what that meant. And the other thing, when we're talking about the vacancies in beds in hospitals, whereas the chair was talking about spare wards, when I've looked at planning for various different things where things are moving over, it often talks about an ideal occupancy of 83% because that allows for people, for example, when planning a car park, you'd look at a maximum capacity of 83, occupancy of 83, because there are cars coming out as there are cars coming in. But that number or that latency doesn't seem to apply to hospital wards.
Yeah, good questions. So vaccination MMR. So we have had issues in LLR with resurgence of measles. We've seen an overall drop-off in childhood vaccination. Again, the county is doing pretty well overall, but over LLR in its entirety, we have seen a drop-off in uptake of vaccination. I think the issues that you're referring to, the Wakefield issues back in the whatever decade that was, I think that calmed down. But I think we had, as Mike referred to, we've got a change in appetite for vaccination post-COVID actually. So we had a real enthusiasm for vaccination during the pandemic, and for various reasons it's waned. We are doing everything we possibly can to increase vaccination rates in our childhood immunisation rates, because it's a common cause of children ending up in either seeing their GP or an ED. Measles is a really serious illness. People forget that because we don't see it very much, but it's a really serious illness that's really important to be aware of. So we're doing everything we've got there. We've got roving vaccination unit. We've got a school vaccination programme that we're trying to promote. In terms of the healthcare bit, the ESR is just our sort of mechanism for the electronic staff record, which is our way of looking at our staff on a rota versus those who've identified themselves as a healthcare worker. So probably not really relevant for this meeting, but it's how we break down that vaccination rate for our healthcare staff. But we could still do better in healthcare staff vaccination rates. Occupancy of beds, I'll hand over to Jean and to Sarah, if that's okay.
So absolutely. If you look to the national best practice occupancy for NHS beds is 85%. That would be a challenge both from the physical number of beds, because no NHS trust would have that, and also then from the financial point of view. So locally, we run our beds a lot higher than that in terms of the occupancy, and in winter it can be up as 98%. It's one of the factors that causes poor flow from ED, feeds back into the ambulance conversation. There is a different occupancy across our sites, because obviously the Leicester General is much more of a planned site than the other two. But yes, in an ideal world, we would be lower than we are at this point.
Okay, thank you, Mr. Chapman.
Believe it or not, most of ours been covered, thank you, Chair, by other people. So I'll let them off. Thank you.
Thank you, Jill.
Cheers, thank you, Chair. Just a bit of experience actually to balance out what Mr. King's saying. I've had excellent service from the NHS over the past 12 months and one-on-one with my little one. So, well, my little one is 15, so he's not quite little, but he is the littlest of the three. Excellent and straight through, not a problem, not an issue. When it works, it really works really well. But I do like your idea about Loughborough. As a Loughborough county councillor, I think it's a fantastic place. I would, but I think it eases pressure and it decants people away from the LRI. And maybe that's something where you can evolve that over not just this winter, but future periods as well. Because if you're living in Melton or Colville or any of North Leicestershire, Loughborough isn't that far away. It's certainly nearer than the city, and maybe if the capacity is there in Loughborough, so maybe that's something to evolve into, to take some of that capacity away and some of that issue away from the city. I'm not saying that's going to be the be end and end all, but I think that we do need a secondary place where we can send less urgent emergency cases, let's say, or emergency cases where actually just a period of monitoring is more than sufficient than actual admittance into a ward. So I do like that idea. And I think that if we can develop that going forward, that would be something that will really help the winter pressures. But yeah, that's all I was going to say, because a lot of my questions have been answered already in the thingy. But I just think Loughborough as a hub or North Leicestershire, somewhere in North Leicestershire, works quite well.
Some little villages that could just do with a big health and landing on. Sorry, I'm being facetious. Mr. Poland.
Thank you. Yes, linking on to what's been said already. You mentioned, Sarah, that the LRI is the busiest A&E in the country. I understand that's because of sheer geography of it. So obviously it's central, a lot of countryside sort of around it, and I understand that is the case. If it's not, correct me, by the way. this might be a very general question, but it's just one I've been curious of. Has any thought ever been given to opening another A&E in Leicestershire? And what would be involved in that? So we've talked about sort of services in Loughborough. Loughborough is not from. I've worked in Loughborough and I'm North Leicestershire as well, although nearer the city. And and Loughborough is not far off a small city in terms of its sort of demographics and needs and so forth. And I just wondered, has any thought ever been given to opening another A&E either there or indeed in the south or anywhere else to sort of help in that immediate location, but also therefore by definition take the pressure off the other LRI?
Yeah, so opening in another A&E, no, because you would have to replicate resource departments, separation children's. It would just be too costly, to be honest, in order to put another true accident and emergency department with all of the facilities. We are the largest, you are right. This is around the geography, the fact that we are a single ED department for an entire, for LLR. And obviously we do have the borders surrounding us that patients go to, so Rutland, etc., etc. What we are doing is we've got a plan to create an urgent treatment centre. Now that is a co-located urgent treatment centre because that is what the national guidance supports, but we've also got plans in place, as we've described earlier, to create urgent treatment centre capacity in other locations, so both in the city and at Loughborough. So ED, no. Urgent treatment centre capacity, yes.
Can I just add that the data strongly supports actually that it's not another ED that we need, it's more urgent treatment centre capacity. So we've done some work that demonstrates that a significant proportion of patients who go into the ED department don't have a particular emergency department treatment or investigation that they couldn't have elsewhere. So that's the neighbourhood model that Pete was describing earlier on. We want to take people out of the ED department, decongest it. And Sarah said we do want one on site, really important for us, for those patients who turn up who can be decanted into that area, if you like. But we want to do that multiplicity of providers around the county, so it's easily accessible for people who haven't got the transport, who can get there quickly and get the care they need, because actually most people don't need an ED department from our data, actually, in terms of that extra demand and capacity that we have. So the neighbourhood model is part of that. It's also worth noting that the neighbourhood model will also look at urgent treatment in the neighbourhood level. So we've got enhanced access already, which are appointments in the evening and the weekends. We've got a same day access model that's being launched as well, to try and increase the amount of activity, seeing patients on the same day in their neighbourhood, in their locality, which is what our patients tell us they want.
So thank you for those answers. So would this be effectively like a walk-in centre plus then? So it's, you access it in the same way we do currently the walk-in centre in Loughborough, but instead of being sent off to the LRI to have something done, I would just have it done there in the site. I just that's very positive then, because Loughborough's sort of the one I use, and yeah, that's great. Thank you.
Mr. Balls. I'm going to channel David Bill for those who are established. There you go. I miss him too. When I first joined Hinckley and Bosworth Borough Council, we were promised funding for a walk-in centre in Hinckley, and it was funding available, apparently £9 million of it. David Bill's in my head now. And that never materialised. Now, Hinckley has just got the diagnostic centre, which is fabulous, but the diagnostic centre essentially repeated the services there in a nicer environment, added a second endoscopy unit and things like that. I see a real need to expand the services in Hinckley. There isn't enough there. We've got the MRI, we've got the new X-ray, we've got the new. We're still hopefully getting a day case unit built with the second tranche of funding, hopefully that's arriving. Mia just said, please pitch for your area, and I'm going to, because I think actually we need more services in Hinckley and Bosworth, and we were promised it before, and it would be wrong of me not to remind strategic leads like yourself that we were promised that funding before for a walk-in centre and they never materialised. So I think Hinckley should be front and centre of any decision making there.
Yeah, So we're very aware of that, and as you say, we're very excited about the Community Diagnostic Centre at Hinckley, really excellent for us and will help us with that neighbourhood approach. It will mean that our GPs can refer straight for diagnostic tests without having to refer to the hospital again, decongesting the hospital site. So very excited about that. We are obviously working through the situation with the capital funding for the Hinckley Hospital, as you said, in the reconfiguration. So it's a sort of watch that space. Active conversations are going on based on the historic recommendations that were made, but looking at whether we've still got that capital in that same way to carry forward. So it's a very live conversation for us.
You have to on the county council as long as David build to see it built. Mr. Piper.
Thank you, Chair. The point you've just made about making I forget exactly the term you use, but small injuries units around reinforces I think my first comment about greater publicity about where to go when. To go back to the Lutterworth Hospital, which now I think that's at least its third mention, they had a small injuries department which was closed because nobody used it. Nobody used it because they didn't know it was there. So when you're opening these things, and I think that they are very useful because I think too many people do go to A&E or ED as you call it, and then that's what causes a lot of problems and possibly some of the problems with your ambulances in their wasn't a tent, was it? It was a anyway. So I think that is very important. The other thing is, going back to what Mr. Mayor said there, that I have to admit that on the occasions when I've been in hospital as an inpatient, albeit a day care in some cases in Leicestershire, I have received fantastic treatment. A&E, bit slow, but yes, otherwise, the NHS is good at delivering what you need rather than when you want it, if that makes sense to you. Thank you.
Yeah, so thank you both colleagues who've given us positive feedback, really important with that. Our staff work incredibly hard on a day-to-day basis. So there's a lot of negative feedback about the NHS, which doesn't help with the retention of staff in the NHS. So really grateful for those comments that you've made today. It is complex because those urgent care centres or walk-in centres, whatever phrase we want to use, they're all slightly different in what they're able to provide, opening hours, X-ray facilities, point of care testing. So that's where some of the complexity comes in. But you'll see in the pack we've got a really comprehensive communication and media campaign, because as you rightly say, it's really important for our patients to understand. The challenge is that when that's on social media and it's out there, most people aren't interested in that particular point in time. It's when they need the services that they need to know. And we're trying to make that information accessible at that point in time where they need them. That also means that they may be redirected. So you may turn up to the A&E department and actually be redirected to an urgent care centre. You may be redirected to your general practice. You may be redirected to a pharmacy if that's what's needed. We have pharmacies now that can offer 7 different types of antibiotic prescribing for different clinical conditions that would formerly just have been in general practice. So the capacity across the system is enormous. We've hit 7.3 million appointments in primary care. So we are absolutely increasing access, but there's an insatiable need and desire for access. And we want to get that access proportionate to patient need, clinical need at the right time in the right place. But we are working very hard on the communications and media campaign for our population.
Right, thank you very much. We've spent a lot of time on that, and let's hope it works. Can I suggest we have a short break until 4 o'clock for a comfort break, and then we'll crack on and sort the last 2 items out. Okay, we'll wait for Mike Sandys to arrive when he does. The next paper is on mental health and early intervention. We're going to have a paper next time more on the wider mental health and the inpatient stuff. So that's why I'm sort of careful. Don't go diving into that under questioning, because this is early intervention. This has been asked specifically by us at our last meeting. Now, I've got David Williams with an infeasibly long job title. Group Director Strategy and Partnerships, Leicestershire Partnership Trust. Alison Turner, Integrated Care Board, and two people I don't know who they are, so you can introduce yourselves. Thank you.
Good afternoon. I'm Chris Harbron. I'm the Managing Director for Vita Health Group.
Afternoon, everybody. I'm Brendan Street, Principal Clinical Lead with Vita Health Group, accountable for the clinical governance and clinical effectiveness of the LLR NHS Talking Therapy Service.
Lovely. Okay. Thank you. Thank you, Chair. We just wanted to say as a little bit of an introduction, we'll just set the scene about what we're going to cover on the intervention side, mental health, early ways of working. But I just wanted a little reflection, having listened to the last conversation for you all. And I just want to say, if there are opportunities when you go and have your flu vaccines, the power of counsellors sharing with their constituents having their flu vaccine is incredibly positive. It makes a really big difference for the community to see things. Some of you, due to the benefits of your age, will have free flu vaccines. For others, it would be a chargeable flu vaccine, but it's a chargeable vaccine at something like £16 in supermarkets. But it's a really good opportunity to counter some of those thoughts and ways of going, and everybody can make a difference. So in today's conversation and way of understanding stuff, we've come to talk about mental health intervention, prevention, ways of working, and just share some of the work that's going on. In terms of setting the scene, what we wanted to just say at the beginning is, and you've got a representative here, so the four of us represent three different organisations working in the field, was that mental health support, early intervention isn't something that's just done by one organisation in the NHS. It isn't something that's just done by the NHS on its own, but it brings together a real partnership service and a way of working. So yourselves as local councillors are involved in our mental health neighbourhood work, ways of working through. We've got lots of services using voluntary and community sector organisations who are tackling loneliness, keeping people warm, providing really specific services. And then there's the GPs, primary care, and ourselves and other organisations as well. Everything wraps around together to become an important part of how do people feel about their own mental health and well-being. That becomes really important because that's how families, communities stay strong. That's how people stay in employment. That's how people continue to be productive in the work that they're doing. So in the presentation we've got today, we're going to take you through some stuff around NHS Talking Therapies, and we'll touch on a couple of areas. We aren't going to be able to cover the whole of mental health prevention and early intervention, but we want to give you a flavour of that cross-working and the ways that things come together. So I'm going to hand over to Alison, who's just going to introduce you to what Talking Therapies is, and then Chris and Brendan will take you into some of the detail.
So thank you, David. Just through a matter of note, really, it's Alison Taylor, just in case anybody is trying to contact me at any point. So I am the ICB lead for mental health development. So I just wanted to kind of set the scene in terms of that national commitment, so that overarching view. So because there is a national commitment to continue funding talking therapies, and that's because it's evidence to get better clinical outcomes immediately following treatment. So, and also a higher personal income for 1 to 5 years afterwards. And studies suggest that for the 670,000 people currently being treated per year through talking therapies, that contributes 4.7 billion to the economy. So you can see why it is supported at a national level. So, and the autumn statement actually saw £592 million being committed to talking therapies over the following years, so taking us up to 2028 with a commitment to really grow that workforce. Now, I don't want to talk too much about that because I will hand over to both Vita colleagues to give you more of that in-depth information about that.
Shall I start then, Alison? Yeah, as I said, I'm Brendan. I'm oversee the clinical governance and the clinical effectiveness of the service. I suppose the mental health landscape, I think, is quite confusing for people in terms of that. What is what for, and where do you go? So I'll just give a quick overview of what talking therapies is for and what good should look like within talking therapies, if that's okay. In terms of talking therapies across LLR, anybody over 16 that's registered with the GP in the area is able to refer themselves in. We don't need GP referrals. It can be self-referral. You can refer online. You can refer by the phone. So it's ease of access is important, and it's for people that are experiencing mild to moderately severe mental health conditions. That might be in the context of socioeconomic stuff that's going on in your life, long-term conditions, whatever it is. If it's a common mental health condition, we will get somebody in, assess them, and then treat them. The treatment we provide it's called a step care model. That just means there's different options for the different level care you need. That might be guided self-help, that might be digital support, that might be one-to-one support. So that's what we offer across the board. We have about 170 clinicians working in LLR at different stages of that step care model. And what does good look like? So we're measured now on completed treatment. So somebody being referred in, assessed as suitable for the service, entering the service and having at least 2 sessions of therapy. They often have more. That's not the average, but that's the measure from NHS England. That's one measure. The more important measure is, do people get better? And you'll see in the paper that there were a number, and I can explain them if you want. But in essence, it's, do people get significantly better from the treatment that we provide? So that's what good looks like. Increasingly, we're working in an environment, and a lot of people have talked about prevention today. They've talked about place and they've talked about digital. In terms of talking therapies, we're aware that we're not just about the mental health of the individual, we're about mental health of communities. So we work really hard in terms of employment support across talking therapies. We work really hard with VCSEs across LLR, and we also have community workers that work within the community outside our business as usual. And that's all about prevention and making sure at a place base people understand the confusing landscape of mental health. Is that a useful introduction in terms of where we are?
Yeah, thank you.
Just going to touch on a couple of other areas that are in the paper just to pick up on that range of things. So there are a whole range of services, lots of other ones, not everything is listed through, but our Mental Health Central Access Point is a partnership between Turning Point as a charity and Leicestershire Partnership Trust, providing 24/7 telephone space for people to go to be able to ask for advice, guidance, signpost, and to support things. There's also then a whole network of voluntary and community organisations and ways of working things through. There's been a real positive engagement in our voluntary community social enterprise alliance with a network of partners all coming together, and it's a really good way for organisations like ourselves, the NHS, to be able to talk together to a group of voluntary community groups, and then individual groups respond in their local geographies for what is right for their community. And actually that reflection on the different things that people can provide has been huge, and there's a whole host of different community groups providing a network of neighbourhood cafes where people can go for a coffee and a chat and a conversation with somebody, so they don't need to go to A&E or to escalate it or to take things forward. The last bit I just wanted to touch on and reflect through was talking therapies is about supporting people with lower level of need, making sure people stay in work, they get the support they want. There's also a really key function about supporting people with severe and enduring mental illness back into employment. And so we provide services there which are working with employers to help them adapt and support people back into employment. And that success rate is far, far higher than employment centres and ways of working things through. And LLR is the 3rd highest performing across the East and West Midlands of getting people back into work with long-term sustainable jobs if they've got a severe and enduring mental illness. A whole range of different things. Our recovery college, we haven't touched on children and the support that goes into schools today in the paper, but that will give you a flavour of the types of intervention work and that focus on prevention and well-being as much as we can. Okay.
Thank you. I was quite impressed by the reduction in waiters, actually. That graph was quite gratifying to see, because delayed getting to speak to somebody, people only get worse. That was a really nice piece of work that's been done there to get that down. So I think to be congratulated there. Anyone else want to dive in? Mr. King, thought you might.
Chair, So look, I know people who've accessed this, and I think for me, so I'll just be clear, I personally haven't, but I know people who have. So I think the improvement in access to mental health care support over the last few years with this talking therapies rollout has been really, really significant. So I think that what you're demonstrating is it's having an effect, which is good. It's just, and obviously not all the data you just mentioned is in this report. So that'd be really useful if you are able to share that about being the best, third best performing in the Midlands or whatever it is. That'd be really useful to share that across. No, this is really important because one of the things previously, anyone trying to get access to mental health support at the kind of low to medium level was quite difficult because people are kind of either fobbed off by the GP or, there's nothing really wrong with you or whatever. So it's really hard. And then anyone, to actually take the step of actually going to see someone, because that was the only route, that's actually quite difficult because quite often people with neurodiverse or some of these anxiety type issues don't actually necessarily recognize there's anything wrong with themselves, and they think, oh well, I don't need to go and see anyone because I'm all right, or they'll just tell me to do whatever. So they have a lot of misconceptions and perceptions about this as well. So I think this is good, really, and I'm aware of the community cafes as well, because we had one in I think we've still got one in Harborough. We used to host it at the council offices in the foyer area. I can't remember where it is now, but I know we've got one down there, and there was people turning up for it, which was really good. I was quite surprised, I think, how many people were showing up, but just shows you. But so it's good about the thing about getting people into work, but equally, I think certainly in our area, 1 in 4 people live by themselves. So actually, who do they go and talk to if they haven't got anyone else living with them? And I think this is a really important thing that maybe you haven't touched on in this report. There's actually a lot of people living by themselves, and if as people get older, well, even at younger age, if they haven't got anyone immediate, and also you've got more fractured family life and everything, so not necessarily people have people on their doorstep they can talk to, etc. And something occurred to me the other day as well, that actually there's more communication by people sending text messages by these bad boys than actually people actually talking and listening to one another, in a sort of verbal communication. And I think we're all guilty of doing that. So, but it just seems there's a lot more of that happening, and that's just a social societal thing. But I suppose my question is, what else is there that you could do? I mean, the only question I got really was about the stage, the difference between I think it says that stage 1 from someone referring, getting self-referring or being referred to get access to a professional is not very long, but then if they need more bespoke support, there's then a kind of delay. And I was just trying to understand how long is that delay. If someone needs a bit bespoke support or more one-to-one program, how long does that typically take, and all of that sort of stuff? That was what I wanted to say. Thanks, Chair.
Thank you. I'll take the first bit and then hand over to Brendan on the detail of the talking therapies element. I guess focusing on text messages, focusing on thinking about things and ways of working, what I'd say is talking about mental health is a really good thing. So being open and talking about mental health is one of the things that society, we're going through a shift. And we're changing that way that, even only a few years ago, it was okay to say that you got some physical ailment, but actually you wouldn't talk about feeling stressed or anxious or worried or depressed. The more we talk and make this part of natural conversation, the more people will seek help, the more people will be open about it, and the more people will respond. So I think it's a really good way. In terms of text messages and loneliness, the first bit I'd say is that while text messages mean that we might not talk to each other as often, they are also opening up an avenue for people to be able to come and have a conversation. So we provide services like Chat Health, which initially started as a school nursing function, which enables a young person just to have a conversation, a text-based conversation with a nurse. We've opened that up, expanded that now into conversations for people who are in mental health crisis, for people with ADHD, for health visitors, for people with neurodiversity. And one of the things remembering is it's not always easy to talk to a health professional if you're a young person. If you're texting and on the bus to school, you're just doing what everybody else is doing, but you could be having a confidential text chat with a school-based nurse, or you could be a crisis conversation that you're having. All of that becomes possible with text messaging, and it opens up a new way of people talking. Some people find it really difficult to talk about how they're feeling, but they feel it's possible to put in there. So there's a challenge, a positive and a curse for us. The loneliness issue, I think, is a really big system thing for us to think through, and tackling loneliness and ways of working becomes not just an NHS issue, but a local authority, voluntary and community sector way of working. And it's really important. I think the 10-year plan and that shift to neighbourhoods is reinforcing that way of saying, how does everybody come together and work on it? There are elements we can do, but for many people, loneliness might mean they come down through an NHS route and end up with a prescription for a pill. Whereas actually what we want is there good community engagement? Are there support for people? Are there places they can go to? Are there groups they feel part of? So a lot of the work we do with your colleagues in social care, with our voluntary community sector network, is to really open up and say to people, here are the different things. Use of the Joy app is a way of GPs socially prescribing. It lists a load of different functions and says, what would you like to do? Actually, there's a walking group that happens on a Saturday that goes around Bradgate Park or something like that. You could go and join that, and ways of working. So a whole host of different things that I think we can all do together. If I hand over to Brendan to pick up some of the detail.
Yeah, cool. I mean, it's a really good point about loneliness, though, because there's a lot of research that indicates that it's as bad for your health as smoking a packet of cigarettes a week. So it's a really good point about us picking up loneliness in a holistic way. And I think the point on sort of access is really important, and we've done a lot of work in talking therapies to try and demedicalise things, because I think, like I say, the landscape of mental health is really confusing for people. They often think, am I poorly enough? And I think we need to get better at our marketing in terms of that. We've just put a new marketing campaign out that's called Look Who's Talking. It tries to use personas, because I want to get people to go, that's me, that is. And you don't often have that in the marketing because it's too medicalised. So that's what we're doing, because if you don't have access, then you're never going to get to the point of waiting, because people never come into the service. I think the point on waits is really, really important. The first step is hard, so we need to get people into assessment really quickly. And you can see from the data around about 9-10 days. We can probably offer quicker because that's offered, not accepted. People can't often get in as quick. Once people get in, they have that assessment. Then going into treatment, it varies on what's needed. If it's more of a guided self-help, probably 2 weeks. If it's a group intervention, probably 2 to 3 weeks. If it's more, we call it step 2, but a lower face-to-face or online intervention, that's probably 4 to 6 weeks. And then at the top end, the mode in terms of the most common wait for somebody that wanted like CBT, so cognitive behaviour therapy for a more complex problem, would be around 3.5 months. But you can see from the data that we're working really hard to get those wait lists down, and I think it's come down by 47% since last year, and those big waits, those 180-day waits, coming down by 79%. So I hope that gives a bit of a context in terms of where we are with that. Yes, Chris.
We can't take questions on the floor, sorry. I'm sorry, you did. Yes, we know. It would be better if this was if you discussed it with these guys when they leave, and you can have a chat outside privately. Because that's the way we run the committees, to keep things orderly and save embarrassment and all sorts of reasons. And all this stuff goes out on YouTube. So I don't know how comfortable you are with that, but I just want you to be aware of it. And it is much better and kinder. I know she is, and she had.
Chair, if I may, Chair, I fully understand your concerns, Madam, and issues, and I'm sure you've got a lot you want to say, but the Chair's right. There's a process we need to go through. It's 4:20. You know, we've all got, this is the last item. I appreciate that's not the answer you want.
Yeah. I was going to say, Rachel, we can pick it up together on a call. I'm happy to do that.
Well, I'm not going to discuss my personal details, but I may have been, and I'm not going to talk about it. Sorry about that. Mrs. Moore is clearly upset and unhappy, and there will be a process. I imagine the coroner will be involved, and I don't wish to prejudice anything that may happen in the future.
Thanks, Chair. And all I wanted to come back and say, I was just going to say thank you for your explanation on the data and explaining the detail of that. That's really helpful. Thank you.
No problem. Mike, do you want to come in quickly?
Yeah, just a quick one for me, just reminding myself, I think Scrutiny did consider an item on isolation and loneliness. I think it was the last scrutiny of the last council. Just thinking, because there's a number of members new to the council and new to Scrutiny, whether is it worthwhile just circulating the link when the minutes go out? Because it actually would provide, we did do quite a bit of detail on the county offer around isolation and loneliness.
Thank you. Bill.
Thank you, Chair. I wanted to echo the Chair's comment about the reduction in waiting time. When I saw this graph originally and I saw how long people were waiting over 180 days, fortunately, I didn't have to wait 180 days when I needed help. I don't know how I would have coped if I had it. And I think that is, I'm going to leave it there. Is mental health becoming the hidden pandemic? We all just seem to hear these days about people with mental health issues. And it seems to be, I nearly said, it seems to be as if everybody's got mental health issues these days. But it's becoming to sound a bit like that. Going back to, I think it was Councillor King who mentioned about people living on their own. I actually found my mental health got better when I got rid of my ex. And I'm sorry, that wasn't a joke. But I can seriously advocate having a pet. Now, in here, when you're talking about steps 1, 2, and 3, that sounds like a song, doesn't it? You go back after something else to mention step 3 again. Is that just a continuation of step 3, or is that to refer to step 4?
Yeah, so in terms, just to clarify the question, in terms of the paper where it talks about steps 1, 2, and 3, and then it comes back to step 3, it may be because a lot of the weights that we're talking around sit in step 3, because that's that's obviously in terms of the number of therapists that we've got, and in terms of the demand, that's the more demand with less therapists. So it might be because of that it refers back to step 3, because a lot of the data you'll see in terms of those weights, particularly that graph that you saw, will be predominantly at step 3, because it's just harder to place people around step 3. So that's probably where that detail comes back in.
Thank you. Who have we got next? Mr. Bulls.
Percy, thank you so much for this work. I think it's so important. We've had a few items today around the future of the NHS, the future of our services and delivery, and none of it's going to be possible if we don't get this bit right, because it's a huge element of modern healthcare. So I want to congratulate you on that. And just one thing on the ADHD and the neurodiversity talking therapies. We had an item yesterday talking about the increase in diagnosis, the increase in people seeking assessment for that. And that number, I imagine, will only rise, and the demand for your services will only rise. And are we in a position to scale this up to cover that emerging need that I think will only happen in time?
I can answer that as somebody with ADHD, so who's very happily medicated and very happy to share that with people. I don't have a problem with that. We recognise that talking therapist doesn't give all of the outcomes that you would want. It's not designed in that way. So currently, and you'll see it as part of the paper, there's actually a development programme and that will be co-produced with people with ADHD, so that then what we can be doing is make sure that that's fit for purpose going forward. So yes, there will be more people, and it comes back to one of the points that you made earlier on about mental health. We've all got mental health. There's a greater awareness about these things now, and social media has a lot to answer to for some of this as well. But actually, that's a really good thing, because it means that people are coming forward and asking for help when they need it. and we're able to promote some of those things. We're not getting everywhere. It's not perfect, and there's a lot of work to do, especially in terms of neurodiversity. So, but we do have long waits, and that's where we're particularly looking to do some focused work as well. So thank you.
Okay, thank you. James.
Thank you, Chair. Mentioned before about the medicalisation or the demedicalisation of mental health. That's quite an interesting thing. So I had some issues about 10 years ago, not on the scale of some of the people that have spoken today, but I remember I was working in occupational health at the police at the time, and I was struggling. Nursing colleagues, remember, she said to me, she said, James, she says, if you're feeling depressed, it's because you've got a chemical imbalance in your brain, and we can treat that. Whether you choose to get treatment for that is up to you, but we can treat that. However, what I would say to you is if you went outside and broke your leg, you wouldn't be debating whether you should or shouldn't go to hospital. Right? And the fact that she managed to put it that matter-of-factly really helped me. So I went off to my GP and I was put on tablets, and frankly, it was great in the sense that it helped me very quickly and you know, wish I'd done it earlier. So I guess it's one of those, it can be a sort of a double-edged sword in that regard. In terms of talking therapy, forgive me, I don't know really what that is in detail, but if that's phone talking, if that's to do with phoning up and getting help on the phone, 100% is a place for that. But I wouldn't want to see a situation where that was a requirement before seeing people in person. I did phone counselling at that time. It was fine for me, although I suspect the person on the other end of the phone just said ranting for a few hours. But that's fine. It was fine for me. But I mean, I've got a mate who's in a very, very difficult position at the moment, and it just would not work for him. It just simply wouldn't. You just have silence on the end of your phone, and without going into his sort of situation, without intervention, that would have been a very different outcome not so long ago, and he 100% would definitely need someone in person. So I wouldn't want to see a situation where people were required to go online or do the text or do the phone, and instead of being able to see someone in person first.
And I think too, it's just to reflect right at the beginning, to take the point about there's a chemical imbalance in your brain, and here is something that addresses it, is about treating the symptom and saying, how do we make things change? What I think we've developed to move forward is about, so how can we go to the cause, and how can we help people really think about the different things that are happening? And that's a lot of what the talking therapist does. So, I mean, Brendan, do you want to then go through a little bit more detail of how?
Yeah, just in terms of that detail and what talking therapies is, it's probably, think about it as almost like a one-stop shop for a range of different options that suit that person's need. So that assessment that you have within 9-10 days identifies actually what is it that you need to get you back where you need to be. Now, for a lot of people, that might be online therapy, but some people, like I say, will need counselling. They'll need cognitive behaviour therapy. Some people would prefer to do that online via Teams. Some people prefer to do it by phone, and there are a lot of people that want to do it face to face. So patient choice is really important there. But yeah, the assessment will go, actually, what do you need to get you where you want to be? And then once we know that, then we place the person with a counsellor, with a guided self-help person, with CBT therapist, and then the choice is there in terms of whether that's face to face or more digital. The digital's interesting because there's a tension, because obviously digital gives you scale to reach more people, but digital then crashes up against digital poverty and deprivation. So we need to be careful with it and make sure we've got other options for people. But yeah, does that make a bit more sense in terms of what it is? Cool.
Okay, thank you. Hardip, join us.
Thank you, Chair. So as part of the Healthwatch contract, we conducted entry review visits to all the 24 neighbourhood mental health cafes, and I agree, thank you for your paper. There's a sort of good working relationship on the ground between making referrals and signposting. However, we did get feedback from patients or those accessing the cafes about referrals access, and I don't know if this is to do with which step, but inconsistencies depending on where they're are referring from with getting access and how long that is. So I would quite welcome an opportunity to perhaps discuss this outside of this group, just so that we can feed that level of detail back to you if you've not seen the report already. And secondly, I agree there is a lot of commitment from the voluntary community social enterprise organisations and sector, but it does come with no or little investment, and community groups are involved because they are constituted to do so and may secure funding from other avenues. So I just wondered what the future might be around that, and if there is opportunities for involvement with some investment around that. I'm completely conscious that there is funding restrictions and it's tight for everybody, but what we have learned through speaking to patients through the neighbourhood cafes and our public engagement is that local support is key, and people feel more comfortable accessing locally based mental health support.
Thank you. Interesting.
Thank you. Thank you very much. Yeah, we'd be happy to have a conversation out and make sure we're picking up on any learning around referrals and ways of working. Be more than happy to work through. I was just having a quick look to see if I can find out the figure in the way immediately, but there is a significant investment, and I'm not going to quote the figure in case I am then the start of the correction at the start of the next meeting. But there is a significant investment of at least hundreds of thousands each year that the NHS and local authorities are putting into voluntary community organisations for mental health support and ways of working. So there is a real focus on investment. There's always going to be a real tension about how much and can we do more, but absolutely there's a big focus on that.
And if I can just add to that, some of the current work that we're doing around kind of ADHD, for example, and looking at talking therapist services for the deaf are involving the community and the voluntary sector as well. So we're looking at how we work collaboratively and utilise any funding that we've got collectively. So it's not a case of this pot of money going here. We're really recognising the input and the value. So they will be part of that whole process and part of that piece of work as well.
And just two really quick ones on that. Talking therapies, again, we see the VCSEs as our partners across the system, so we need to work well with them. So we do put on, there's around 40 now sort of sessions that they can drop into in terms of mental health awareness, mental fitness, what is mental, that they can join, so we can train them up to help us do what we need to do. I also just realised I'd done something that I didn't want to do and said a lot of acronyms. So for CBT, cognitive behaviour therapy, is just a term for the most evidence-based type of therapy that covers things like panic, depression, anxiety, whereas counselling is a bit more broad brush in terms of life decisions and wanting to change things. I just realised I'd said a lot of acronyms at you and I thought I meant not to do that, so apologies. I'm a clinician, just forgive me.
NHS is drowning in acronyms, so we get used to it. That was really useful. Thank you very much. It's great to see the partners and the guys delivering this together, able to come and answer questions, which is, I think, the first time I can remember it here, but then I've not been here for a few years. So thank you very much for your time. That was really good.
Yeah. So thank you. I'd like to cordially invite anybody along to any of the sessions. So if you want to come along and actually find out what talking therapies is, there are different sessions happening in different parts of the community. So please give me a shout, give Brendan a shout, and let's get you really engaged with some of it if you'd like to be part of that.
Yeah.
Thank you for that invite. Would you be able to circulate your details maybe via you, and just so that because that's something I think that I wouldn't mind doing, and I know colleagues would as well.
That's great. Thank you very much. So our final item is the refresh at year 3 of the 10-year plan. Don't ask Mike about the missing year. Of the joint local health and wellbeing strategy. So it's having a bit of a look over. We've got Josh Namavany, the Assistant Director of Public Health, Abby Vaughan, Director Health and Wellbeing Board Director, and our own Mike Sandys. So when you're ready, please kick off. There's a lot of removal of COVID, I'm pleased to say, till we get the next one. Sorry, I'll keep winding people up with that.
Yes, indeed. Thank you, Chair. So aware that we've been going for some time, but last item is just our refresh of the health and wellbeing strategy as you were setting out. I'll hand over to Abby and Josh to take us through it. The only thing for me to say is just to remind you, as it says in paragraph 1, Health and Wellbeing Board, obviously a multi-agency organisation, which is a subcommittee of the County Council. We were ahead of the NHS in publishing a 10-year health plan back in 2022, but as you said at the start, we said we'd review it, so not a rewrite, not a new strategy, but a review of where we're up to. In terms of the commitments in it, which we said we do every 3 years, leaving a spare year at the back of it. In common with the NHS, I'm also now reminded, of course, at the end of this strategy will probably come, well, the council in some way, shape or form won't exist in its current form given LGR. But let's gloss over a couple of those reorganisation bits, and I'll let the other two plough into the detail.
Just before I start, probably need to declare that I live in the Black Country just based on your previous items. So whether that's for my sins or not is up to you to decide. But
hot pork sandwiches will be available to all and sundry at the end.
Yeah, but the purpose of this report is to seek the views of yourselves on the recommended changes that we've made to the current joint local health and wellbeing strategy as part of the current review. As Mike said, this is the Health and Wellbeing Board has a statutory duty to develop and publish this strategy. It's a 10-year strategy that was approved by the board in February 2022, and we reached its 3-year review milestone in February of this year. So it's now undergoing that scheduled review with the purpose of ensuring it remains relevant, responsive, and impactful in addressing current and emerging health and wellbeing priorities. The strategy is built around a life course approach. So you'll see within the document there are 4 strategic priorities, from best start to life, going through to staying healthy, safe and well, living and supported well, and dying well. And then we've got 3 cross-cutting priorities at the moment, which are health inequalities, COVID recovery, and improved mental health. So putting those together, they form the backbone of our efforts to improve health outcomes and reduce health inequalities across Leicestershire. The delivery against those priorities is through 4 dedicated subgroups who report back to the Health and Wellbeing Board on progress, and that ensures that the strategy is not just a document but a living framework for change. So it was agreed by Health and Wellbeing Board members at a development session in July that the life course approach was the right approach for us locally. So the review focuses on the commitments rather than the life course priorities themselves. The Health and Wellbeing Board also approved that the review would be led through the subgroups, and they are the subject matter experts. The review commenced as planned in February. That's been led by a steering group that's got diverse representation across system, place and neighbourhood, and includes voluntary sector representation as well. We started that work off by producing some data packs to provide more up-to-date data. The subgroups have then reviewed those commitments to see whether, based on the data packs, whether the activity or performance has remained stable, improved, got worse, to then determine whether those commitments are still relevant, needed to be removed or needed to be changed. So that's the work that's been carried out as part of the review. As Mike said, it was meant to be light touch. It ended up being a bit more in depth than we first anticipated. It wasn't the intention, but I think, as you'd mentioned briefly earlier, things like COVID recovery were a big, massive change to that strategy document. It was needed. So what we didn't want to do is say we're doing light touch and leave it be on that basis. The report's got appendices that's got a lot of detail on the changes that have been made to each of the commitments and some rationale. There is also a high-level summary within the report that I don't want to go to in massive detail. That's from 18 to 23, paragraphs 18 to 23 of the report. But just some high-level themes that emerged when the subgroups reviewed those commitments. When we reviewed them, there was a mix of things that were actually success measures rather than a commitment, or it was a vision rather than a commitment. So this has helped to tidy some of that language up and make it more clear. Some of those commitments were outdated. So talking about COVID recovery on its own and not thinking about emergency preparedness in its entirety, for example. There were some strategies that
that are that no longer exist, and then we've got newer ones coming through with the NHS 10-year plan as an example. There was a lot of duplication and overlap, and it created confusion about who was doing what and reporting up to Health and Wellbeing Board. So it was difficult to then manage and track. The data showed some new issues, some new and emerging issues. So there were some new commitments added. Some of the commitments were so detailed that it didn't give flex when you were developing your delivery plans, and some were so broad it was actually quite difficult to identify its direct impact on health and well-being. So that's what we picked up through the review. Really what we found is that the majority of the strategy still remains relevant and fit for purpose, but really what was required as part of the review was refinement, just to provide that clarity and effectiveness. I guess it's just providing some assurance that we haven't dropped huge numbers of commitments. It is more just providing a bit more refinement to it. So in terms of next steps, we will. The aim is to present those recommended changes to the next Health and Wellbeing Board meeting, which is on the 25th of September. I've got it here today as part of engagement with yourselves.
Thank you very much. Mr. Balls.
Thank you very much. I'm glad you said it was more extensive than you thought, because it is significant, the changes. And I am concerned that unless we can track the changes and where the overlaps were, we can't give true scrutiny to this. I'm just going to pick out some examples where I think, listening to this report and my first scrutiny a few months ago, I can't see how we can listen to that and not be reflected in some of these plans. So the first one is this: we removed the line on supporting 1 and 2 year olds with vaccinations. Well, we've heard the importance of that today. That's gone. And I know there might be overlaps and it's in somewhere else, but I can't track that. The next one is support for 16 and 17 year olds in education. We had a report yesterday around the importance of that and why it's important to encourage and support them through that. Another one, and this is again going back to my borough council roots, about access for transport services for the elderly, removed from the strategy. I know from my own residents, lack of bus service is the biggest isolating factor for the elderly in my villages. Another one is about fuel poverty and support for families heading into winter again. Another one about healthier choices and better eating. We've talked about the burden on the NHS. If we're not supporting that level of interaction, are we just condemning the NHS to more problems? And the final one is on sexual health. We had a report last month around HIV about late diagnosis and the increase in that. If we're removing that from our strategy, and it might not be, but I can't track those changes. So thank you very much.
I'll start. In my mind, there's probably a couple of bits, and I'll look to Abby and Josh to take it forward. Some of that is about where we've condensed and combined things. And actually, I suppose that leads on to a conversation about what next in terms of a delivery plan and an action plan. And then the other bit in my mind, and again, I'll ask these two to expand on it, some of the things around NEAT, for instance, you're quite right, but I suppose that's them being clear about whose job is it? Does it sit with the Children's Partnership or does it sit with health? And I suppose some of that clarity is then going, no, you're absolutely right, that's really important, but it belongs there, and then they can feed in and tell us what's going on instead of us looking at each other going, are you doing that as a partnership or are we? So that's my thoughts. I don't know if you want to carry on from there.
Chair, just to give you some confidence in what we've changed, a lot of the information has been moved. So the elements that you've cited will actually form part of a delivery plan. It didn't sit well as a commitment because, for example, healthy choices incorporates smoking cessation, sexual health, and we wanted to have an overarching commitment around healthy choices. So we would move the sexual health element that you mentioned as part of the action plan under that, and we can also have a degree of flexibility with that. We're not really doing anything on vaping at the moment, and we could do something around vaping, so we had a bit of flexibility. So it's just making those commitments more high level and moving some of the existing commitments as actions in delivery plans, so we're not actually losing them. So I'm sorry if that wasn't clear in the appendices.
Just to add to that bit as well, I think that's the next step for us. So I appreciate it will be visible on this because it looks like we've removed quite a few bits. But once we've taken it to Health and Wellbeing Board to seek that approval, the next step is to then work on developing those delivery plans, and that will provide essentially the meat on the bones of exactly what priorities are. But also, as we continue to monitor performance, then those can change. So if it becomes HIV under sexual health, it might be something else in another year, and we won't we couldn't have that flex at the moment. I think that's what we were trying to show.
Just on the back of that, I'm thinking, is it worthwhile then? I'm looking at you and as well, thinking about bringing a kind of annual, and we do an annual report, but I'm thinking an annual report around performance to scrutiny. Obviously, we do the annual report to Health and Wellbeing Board on strategy progress, but we could, couldn't we?
We do already, so yeah, that would be factored in. We bring an annual, yeah, we bring the Health and Wellbeing Board annual report here, and that would contain that. But I think it's the delivery plan element, I think that's missing, yeah.
Yeah, that'd be useful, even if we had it just as an information item, so you'd know it was there.
Sorry, that's what I was thinking. Is like we've always done the update report on what the Health and Wellbeing Board has done, but if we linked it to the delivery plan, so you could then track the performance against kind of individual actions, then it would add a bit of detail to that, wouldn't it?
Thank you, Councillor King.
Yeah, thanks. Yeah, so I'm not going to go through, you'd be pleased to know, Mike, every single last line of your thing, because there's far too many of them and I want to go home. Just to have a quick word about this best start for life thing, and I kind of get that, the 1001 critical days, which I know someone came up with that years ago, and about all of that sort of stuff, early well-being and all that, school readiness, that all makes a lot of sense, you know, getting kids ready for school, all that sort of stuff, preparing for life. Okay, well, it kind of makes sense. So that's talking about when, you know, people as they're growing up and they're getting older, becoming adults and transitioning, etc., etc. Fine. But what about older life then? What about people as they're going the other way? Where's that covered? I mean, it's obviously not the best start for life. That's perhaps, you know, a bit of a misnomer really, but it is also, you know, as people are getting and living longer, and the ONS is saying a lot more people are going to live a lot longer and a lot older. How are we kind of, and this is a long-term thing, so this is what we're looking at. How is this, instead of calling it the best start for life, what are we, has any thinking been done about this, looking at the, you know, increased demand, and as people get older they stop working, so then they're transitioning from working to not, you know, doing other things like volunteering, or they might not do anything at all. What is it we're doing there? And that's the bit I'm not getting from this overall thing. Yeah, we're focused on the best start for life, and I get that, but what about the other end of life, when people are kind of, I don't want to be morbid about it, but obviously, you know, at a certain point, they're going to get to the end of their life, aren't they? So what are we doing in regards to that as well? People still want to live well, even if they're, you know, thinking of some people I know in the late 80s, early 90s, or 101, 102 years old. They still want to live well as they can. So what are we doing there? Thank you.
That's where the living and supported well section comes in. So that's capturing that bit, which is why we've done it as a life course. So the best start for life is focused on those earlier years of you, as you've said, and then staying healthy, safe and well is about that preventative, all those sort of reducing harmful behaviours, etc. And then it's the living and supported well space of those of working age, but also those with long-term conditions and living longer. So that's how it's kind of mapped out.
I think the only thing I'd add to that is, yeah, I mean, you know, paper talks about living and supported well, and the work of the integration exec in doing that. The only thing, I'm getting ahead of myself a bit on this one, has been speaking to Liz Orton in my team about what could we do, and it's from public health, but we should take it into the partnership arena, about almost having a healthy ageing principle, if you like, across Leicestershire, because at the moment, I suppose if I looked at the stuff in paragraph 20, there's a lot about living and supported well. It's about support for carers, it's about falls prevention. There are things that you'd recognise as being important. It's maybe not quite the same as taking that kind of whole Leicestershire approach to how do you have a society that really grasps healthy ageing, in terms of everything we talked about earlier on around connection with people, social isolation, keeping yourself physically active. So it's an emerging conversation I've had with Liz, because I know she does a lot of good stuff around falls prevention, but kind of moving into that space, as the phrase goes, and maybe pushing that through the Health and Wellbeing Board would be a way to sort of make it a bit broader than maybe it comes over at the moment.
Yeah, I mean, I can see there's a section about dying well, but I mean, you know, obviously that's going to get complicated because of the Parliamentary Act. I'm not sure whether it's got power yet or not, but that's going to inevitably complicate those matters. But without getting into that kind of very end point, is that, you know, if someone's retiring at 68, say they might retire before that, but if they get their state pension at 67, 68, say, they might retire before that, but they've got a lot, you know, perhaps 25, 30 years of living they've got to do. And this is the bit I'm not sensing that we've kind of, and Mike, I think that's a very sensible idea to, but it does need a whole system look at, because what are we doing? Because people are still working, you know, in the 70s. Thinking of one or two people in this organisation without mentioning any names. But that's a reality, you know, that's a reality. People are continuing to work because they feel well enough to carry on working at a very high and very senior level. You know, that's, thank you.
I just wanted to mention that the subgroup Staying Healthy, Safe and Well does cover all ages as well. And that does look at things like healthy environments, healthy and safe communities, healthy choices, healthy weight, food and nutrition, which spans, you know, the younger generation and the elderly as well. But it's probably not that clear. Thank you.
Yeah, make it explicit, I guess. James.
Thank you. It's interesting sort of report to read through. It mentioned some of the changes in legislation, that no one born after 2009 will be legally allowed to smoke. People seem to drink less. That's just my perception. I haven't got stats to back that up than they used to. They certainly seem to smoke. I mean, I remember when I was a kid in the 90s, sort of most of my granddad's generation that would smoke, and it seems a lot less common now. So those things are obviously positive, but one of the sort of slight going in the other way is a change of lifestyle, change of society almost to be a more, is it sedimentary? So we're sitting down more, sedentary. So you know, my granddad would smoke and have a full English, but then he'd go and work on the docks or whatever, right? But now we spend a lot of our lives behind computers, sitting down, and that therefore has an impact, I guess, in terms of exercise. People that should be eating better and don't, should be going to the gym and don't. Perfect example of that, I think, myself. So I've read a few places, including one just this week, that said people born after the war are less likely to live to 100 than those born before the war. And elsewhere I've read as well, again, I can't speak for the sort of the accuracy of them, that likewise that people of my generation and I guess around it would be the first generation in recorded history that will die on average younger than our parents. Okay, which again is the first time in recorded history that's happened, which I guess is to do with the lifestyle, the lack of exercise. So with that in mind, is the biggest challenge sort of looking forward less trying to stop people smoking and drinking and more trying to get people to exercise and eat healthily and to have that in their mind? Is that going to be the big challenge of the future, do you think?
That's one of the ones that's coming up. The other thing that's coming up in terms of the sedentary lifestyle is the screen time across all ages. It's not just behind a desk, but it's young people on iPads and phones all the time. So there's all of that we want to add into this piece of work. But yeah, absolutely, physical activity, food and nutrition, the work linking into the fast food takeaway policy, all of that we want to be able to consider.
Just to add to that, I mean, again, I suppose we bring in the report about the kind of review of the strategy. That's not to say that there isn't a deal of work, both with partners and through kind of core public health, around a number of things. You know, we do the work on smoking, still the single biggest cause of ill health and death, 50-50 with obesity. Within obesity, I mean, I think when we did the overview of public health work back in summer, actually, yeah, it would be the last Scrutiny meeting. You know, there was that focus on, we've got a good physical activity offer, but we probably do need to do more around healthy eating in Leicestershire, and we're working on that kind of whole systems approach to obesity. Could talk a lot about government policy, because I was interested when Pete was presenting earlier on about what was flagged up around prevention was kind of national stuff, which tends to lend itself towards banning things. So there was the smoke ban. I'm not going to say that's not a bad thing from improving the health and well-being of the population, but there is probably something about wanting to celebrate more about what we do locally to support people, certainly within the council and within our district colleagues. But maybe there's there's a conversation with the NHS about doing their part of the kind of local support alongside it. But no, you're absolutely right. We've made really good progress around smoking. Drinking and young people is an interesting one. Young people are drinking less. I'm trying to make up for them, really, personally. As is the rest of the team. But yeah, in terms of physical activity and food, then food is, that kind of whole systems, food and diet, I think is the one that, again, I highlighted it as a priority within my annual report last year.
Thank you, Bill.
Thank you, Chair. It was interesting that you just mentioned screen time. I didn't grow up in the 90s. I didn't have that. I had the pleasure of growing up in the 60s, which was a much more enjoyable time. And one of the things that we see these days on social media is pictures of what people look like on the beach in the 70s and what they look like. Yeah, they were a lot slimmer there. When I was growing up, I feel like I'm in a walking stick now. We used to have a television program called Tomorrow's World. And one of the last episodes that I remember seeing of Tomorrow's World, where they were concerned about the amount of time children were spending watching television. So what they did was they got exercise bicycles and they wired them up to a generator or something, and children had to use the exercise bike for so many minutes to get an hour's television watching. I've never seen that put into practice, and I think that have we missed something there? Because I mean, it's not the children, it's not just the children that need the exercise. It is the likes of me, and I'm not going to mention anybody else's name, but I think that's one of the biggest things we've got, but we have these great ideas and they don't seem to have done anything.
They asked to bring Tomorrow's World back. I love that programme as well. I used to watch it with my dad. There's different parts to that. I think it's physical activity is one of those biggest. The impact on physical activity is huge with screen time. I think there's the other bits. It's what children are viewing when doing screen time. So it's the mental health component. It's also the bit about being outdoors. So I think it's not to disagree with what came up on Tomorrow's World, but I think there's a broader impact of screen time that needs to be considered that the kind of bikes probably wouldn't achieve. But yeah, it's all of that, considering all of the impact and what we could do differently.
Again, colleagues in Active Together could talk a lot more about physical activity than we could. Exercise bike's an interesting one though, isn't it? It's like, yeah, there's a reason why people don't do that. It's because it's very boring. So that bit about how do we make the environment one where you want to go outside and do your exercise outside and you're not spending, subscriptions on gyms. It's all stuff that colleagues in Active Together and Public Health work on.
But one of the things which they do in gyms, they tell me, is they put screens in front of the exercise bicycles and the treadmills. So you're watching something there. Maybe you're watching The Simpsons or something on that whilst you're getting your exercise.
Yeah, Camille.
Can I just add that one of the benefits about this strategy is it's jointly owned by the partners. It's not owned by Public Health or Active Together or ICB colleagues. So we can all bring our ideas collectively, not duplicate work, and work together to try and improve some of these outcomes that that we've identified in our new priorities.
Thank you. Thank you for hanging on to being the end as well. As a militant pedestrian, I'm all for walking, but that's just me and my strange ways. Mike, you want to have a final say before
Yeah, that's 2 words. William Willard.
I actually prefer the RAF pilot, those names.
That is the name of the book. So there are no more urgent items. Our next meeting will be Wednesday, the 5th of November. We can bonfire, set fireworks off at 2 p.m. And I will draw the meeting to a close. We managed to be 4 or 5 o'clock, so congratulations. Thank you.